各位来宾，大家早安！身智衰退症国际研讨会即将开始，请各位来宾尽速就座，并请您的行动电话关机或转为震动模式，以免影响场内会议的进行。提醒各位学员，本次课程已申请公务人员、西医师、老年医学、家庭医学、护理师、专科护理师、药师及营养师的学分。如欲取得相关学分，请务必完成线上签到、签退表单以及会后的满意度调查表。谢谢您的合作。Good morning, ladies and gentlemen. We are delighted to have all our guests here attending International Symposium for Physio-Cognitive Decline Syndrome. The symposium is about to start. Please turn off or set your cell phone to vibration mode. Friendly reminder, don't forget to fill online sign-in sheet. Thanks for your cooperation. 各位来宾，大家早安，欢迎莅临身智衰退症国际研讨会。Good morning, ladies and gentlemen. We're delighted to have all our guests here attending International Symposium for Physio-Cognitive Decline Syndrome. 首先，让我们欢迎国立阳明交通大学林奇宏校长上台致辞。First of all, let us welcome Professor Chi-Hong Lin, the President of National Yangming Jiao Tong University, to give the opening remarks.
Our distinguished guest, Professor Arai, I believe is online. And locally we have Professor Chen and a lot of experts from Taipei General Hospital and the associated hospital, and all the attendee online. Good morning. My name is Chi-Hong Lin, and on behalf of the National Yangming Jiao Tong University, I welcome you all to attend this very important international conference. This is on an issue of Physio-Cognitive Decline Syndrome, and I think this is part of the general science and or geriatrics, gerontology at all. I believe this field is evolved very fast, and new terminology reflects different focuses in the field will keep on going and appear in the future. So I think this is a very, very important issue. The global aging is a huge challenge, despite most of the focus recently is on the pandemic. Just recently we have this Omicron, a new variant that keep on knocking the door. But still, I think aging is a long-term effect, poses a very long-term effect on human populations. And so we should really, not forgetting this imminent threat on the doorway. So I think without further ado, I certainly would like to appreciate all your attendee and sharing of experience and knowledge. And I wish you all have a very fruitful morning on this very important issue. Thank you.
谢谢林校长。接下来有请日本国立长寿医疗中心荒川秀典理事长致辞。Thanks, Professor Lin. Let's welcome Professor Hidenori Arai, the President of National Center for Geriatrics and Gerontology, to give the opening remarks.
Distinguished guests and ladies and gentlemen, 大家好. Welcome to the International Symposium for Physio-Cognitive Syndrome. My name is Hidenori Arai, the President of the National Center for Geriatrics and Gerontology, Japan. As you know, population aging is a global phenomenon, and in most of the developed countries, the number of disabled older people is increasing and casting a huge impact on the society. In Japan, dementia is the top cause of disability since 2016, although stroke used to be the top cause of disability in the past. So the prevention of dementia and disability is the highest priority for healthy aging in our country, as in Taiwan. As you know, there is a significant interaction between brain and physical function, and we know older people with cognitive impairment and physical dysfunction have a higher risk for dementia than those with cognitive impairment and physical dysfunction alone. That's why IAGG came up with the idea of cognitive frailty, in which cognitive impairment and physical frailty coexist. However, there are lots of debates about the concept of cognitive frailty, and we know the discussion of pathophysiology of cognitive frailty is lacking. That's why Liang Kun-Chen came up with an idea of PCDS to deepen the discussion of pathophysiology of the coexistence of cognitive decline and physical frailty. We are collaborating with Liang Kun's team to define PCDS and to study the mechanism of PCDS, which is very exciting. Additionally, Liang Guan and I have been discussing to hold an international symposium on PCDS in person, but it's still difficult to get together in person at the moment due to the pandemic. So I hope we can discuss a lot about PCDS virtually in the symposium and further expand our knowledge of PCDS. I do hope everyone will enjoy the symposium and hope to see you in person. Many thanks for your active participation.
谢谢林校长及 Professor Alai。接下来有请 Professor Alai 为我们主持。Thank you, Professor Lin and Professor Alai. Let's welcome Professor Alai to host the following session.
Okay, let me introduce the first speaker of this important symposium. The first speaker is Professor Liang Gongchen, Superintendent of Taipei Municipal Gandao Hospital, and also he's a professor of National Yangjiaotong University, Taiwan. The title of his talk is Physio-Cognitive Decline Syndrome from Conceptual Proposal Phenotype to Etiology. So let's welcome Professor Chen.
Thank you. Thank you, Professor Lai, and I'm very happy to be here sharing some of the idea and in the past few years how we developed the operational definition of this phenomenon, and I would like to show you some of the result until now. And I believe there are some other talks who will focus on other issues, so I will skip some of them, but I will focus on the conceptual framework and the definition and potential pathophysiology. So nowadays, longevity has become a universal phenomenon. So everybody will live much longer as you expected. So the question and the challenge is what kind of longevity you want in your later life. And of course, I think everybody will agree that we're hoping to have a healthy longevity, which means try to compress the period of disability and dementia in your lifetime. So we want to enjoy more healthy span instead of just prolonging our lifespan. So based on the previous WHO's propaganda that WHO is hoping that health is for all. And health for all is not enough nowadays. It has to be for longer as well. So it has become the current challenge all over the world. And WHO has published the global aging, anyway, so I forgot the whole term. They have published a lot of ideas to trying to address the importance of the functional ability and the intrinsic capacity. So based on the principle of the public health. So we have to make a lot of effort all across our life trying to promote the intrinsic capacity and the functional ability. And there are several publications issued by the WHO. They have conceptual frameworks, they have strategies, and they have action plans. So if it is because of the COVID-19, otherwise from the 2020 to 2030, it will be the decade of healthy aging from the WHO. That every continent and every country in the world will spend so much time and manpower to introduce the new idea and to change our healthcare services and even the health promotion activities. So I think that is a very challenging issue that when we look at an older person, a frail older person without disability and dementia, and you look at a person standing over there who is frail, disabled, or maybe have some cognitive impairment, but there are so many complex contributing factors across the lifetime. Traditionally, when we do our research, we tend to start from nothing, from people's you're completely healthy, and then to develop the first risk factor, second one, and some new disease onset to impact the health in your later life. But the question is that when you're getting much older, all those factors are mixed up together. But in our traditional research approach, you will focus on one single factor, one single organ, one single pathophysiology. But eventually, all those things, they are very mixed up and they're interrelated with each other. It's very difficult to take the traditional research approach from the robust to the first risk factor and then to the others. So we have to change a little bit. That is how we're thinking about, that we have to begin with the end in mind. So that's focus on the end point that we really don't want to see it in the later life. And so that we going back to see what's the really important factors. So when we're doing the aging research or in the geriatric services, the most negative adverse outcomes is disability and mortality. And if we focus on that situation, so what will contribute to the disability and mortality? If you're a person doing the physical health research, you would say people may start from robust to pre-frail and frailty, then move to disability. If you are doing dementia research, you would say people start from normal cognition to MCI and to dementia. With advancement of dementia, you will become physically disabled as well. But that is stratified based on your specialty. So you're doing physical health, you think about disability. You're doing dementia research, you think about cognition. But in the real world, they are quite mixed up and they are heavily interrelated. So if you focus on a person with dementia, they may be physically active, but may also be frail. So there's a lot of heterogeneity. It's very heterogeneous between those subjects, even though you're just trying to classify them as one single category. But eventually, they can be very, very complex in the nature. So that's focus on the end. And if we dig back to the very, very beginning, so if you look at those persons that are at the end of disability and mortality, there may be several different trajectories. Some are going through the physical part, the others go through the cognition part. But if you're going back a little bit further, you will find that the risk factors for the physical decline and the cognitive decline eventually overlap as well. There are a lot of cardiovascular risk factors, inflammation markers. So aging, in some way, they share the same common risk factor and the same common endpoint. But they have different trajectory to develop in their phenotypes. So why is this important? Since we have the same beginning and the same endpoints, why is the process important? Because so that we can develop different treatment approaches. That is the concept, the core of the precision medicine. We need to do something that is really effective by identifying appropriate treatment to specific phenotype. So sometimes we're doing, nowadays, the precision medicine, they may use genotyping to subtype the patient with the same disease, like lung cancer for the adenocarcinoma. But nowadays, we're doing genotyping for the adenocarcinoma so that we would know what kind of specific chemotherapy or the target therapy can be the mostly effective. But what about the phenotype in aging? That would be the same thing, same spirit. So we have to find a different phenotype through their physical or cognitive presentation so that we can develop different treatment. That is the main purpose. So conceptually, it's like that. But what about in the real world? That in the epidemiology, does that phenomenon really exist? Whether in your aging process, will the decline of physical health and the cognitive health will occur at the same time? And the answer is positive, that from the cohort study for the 3 years, you will see that as people getting older, that your prevalence of physical frailties is growing, but the mean MMSE score is dropping. And if you do some subtyping among those combinations, you will see that, of course, those who have no physical and cognitive impairment has the best prognosis. But there are several different survival curves, that you're having simply physical frailty without cognitive impairment versus those with cognitive impairment but without physical declines, eventually they show different trajectory of in their survival. So there are several different subgroups, even though we're thinking that aging will share the very similar result, but eventually there are several different trajectories. And studies have shown that if physical frailty can be a very, very effective and strong predictor for the incident dementia of all types, not just for Alzheimer's as well as the vascular type. So physical frailty can precede the occurrence of dementia. So that makes physical frailty is a very strong risk factor and an early marker for subsequent dementia. That also changes some idea of the neurologists. They're thinking that dementia, nowadays we're checking a lot of memory tests, but maybe physical part is also an important risk factor that can be easily detected, or maybe they have different presentation and should be intervened as soon as possible. A cohort study in Taiwan has showed that not just to reaching the endpoint of dementia or disability. What about in the aging process? And which one comes first? The physical decline and the cognitive decline, which one comes first? It seems to be that physical decline comes much earlier than the cognitive impairment. But in this cohort, the measurement of physical health are using frailty, but the measurement of cognitive health is using SPMSQ. That is not very sensitive to early cognitive decline. So although the result shows that physical decline comes much earlier than cognitive decline, but because the differences of the instrument, that may not be really the case. Then, based on those epidemiological findings, we have some curiosity whether the co-occurrence of the two declines, are they just a coincidence, or there are some sequential consequence effect, or they are very strong. There's a very strong causal relationship between the two. So this is our curiosity. But that curiosity does not only unique in our research group. Some previous researchers have noted similar phenomenon. So the IAGG, they have operationally defined this phenomenon as cognitive frailty. And they're saying that a person with physical frailty plus MCI can be classified as cognitive frailty. But that is just a hypothetical conceptual proposal. At that time, there was no epidemiological evidence supporting the importance of this definition. A few years later, some studies from the US, they show that eventually the prevalence of cognitive frailty defined by IAGG is very, very low, because the prevalence of frailty usually is only 7% in the community. And if you are going to plus MCI, it will be dropped to around 2% only. 2% in the community sometimes does not really make an impact. And most important of all, studies from a cohort showed that eventually cognitive frailty defined by the IAGG does not predict incident dementia or further cognitive decline. But simply using slowness plus MCI plus MoCA defined cognitive impairment can better predict incident dementia. So that operational definition of cognitive frailty proposed by IAGG may be problematic. So some other researchers trying to modify the definition by moving a little bit backward from physical frailty to pre-frailty, from MCI to subjective cognitive decline to SCD, to have different combination, trying to prove this concept eventually can capture important people who are at risk. But that conceptual modification does not have a lot of epidemiological support. So there's still a conceptual proposal. Another group in New York, Albert Einstein Institute, Professor Joe Verghese, he proposed another term, and he is a geriatrician and mainly neurologist. So he proposed a term called MCRS, motoric cognitive risk syndrome, because he think at his time, he's pretty earlier than the IAGG's definition. He think that eventually he has noticed that gait speed changes is a strong risk factor for dementia. So he used his definition is slowness plus subjective cognitive complaints. So the only reason is that doing that is that in a community that you need not to do a lot of neuropsychological tests. You just check the gait speed and their subjective cognitive condition. And he successfully defined the people who are at risk and observed them using different cohorts internationally and published in Neurology, saying that it is true that MCRS is important and they will capture the people who are at risk of dementia. And the overall prevalence is around 7%. 7 to 10%, less than 10%. So that means much more than cognitive frailty for the 2% prevalence. And some MRI study, they're trying to explore where is the organic lesion, where is the gray matter deficit for the MCRS. And they found there will be the gray matter deficit in the prefrontal and the premotor area. But one of the challenges is that at that time, those MRI cohort, they did not really take the image of cerebellum. They are more focused on the cerebrum. And that is not a very, very significant finding, that because aging is involving the prefrontal lobe is nothing new. And you're saying about the slowness and the involvement of the premotor area is also not surprising. But however, in the Asian populations, using the subjective cognitive complaint can be very, very problematic. That would be generating a very high false positive rate. Several studies done in Korea and other Asian countries, they found that if you move from the objectively measured cognitive assessment to the subjective description about the cognitive decline, there would be strong confounding of depression and the psychosocial factors. So in Korea, they said that if you ask the senior persons whether you have cognitive declines, over 70% of the senior citizens will respond yes. And the severity is related to depression instead of the real cognitive performance. So probably we still need some objective measurement. Based on those previous definitions and the findings, we think the operational definition of this phenomenon is not good enough, either the cognitive frailty or the MCRS. They did capture something, but not really capture the whole picture. So we're wondering whether we can define something to capture the real phenomena and the people who are at risk for unhealthy aging, because healthy aging pursues the functional ability. So those who has the risk factor or at risk of further either disability, dementia, or mortality can be the people who are at the unhealthy aging state. So we want to have a better definition to capture those people. And the second thing is, until now, very few papers answer whether that phenomenon is reversible or not. People do epidemiological study, but no randomized control trial. So if you just pick up a phenomenon that is irreversible, then probably that's not good enough. Of course, scientifically, we can have some new knowledge, but back to the real world, we want to change people's life. We want to help people to pursue healthy longevity. So we need to have intervention evidences, so that will be more practical. So we move back to our own data. So we want to make our own definition for this phenomenon. So first thing, we focus on our cohort, doing the latent class analysis to see whether physical frailty has a different subtype. And the answer is yes. Before us, the original researcher who defined the physical frailty, Lina Frey, she refused to, no, she said there's no subtype of physical frailty based on her data. But based on our data, we did identify there are some subtypes. One is a mobility type, another is a non-mobility type. The mobility type frailty person are older, thinner, having more multimobility, have much less bone mass and muscle mass, and they have poorer cognitive performance and higher mortality risk. That seems to be related to musculoskeletal and neurological system. And another subtype is non-mobility type. That is younger, bigger, having higher cardiometabolic risk and more depressed. So that's more like the cardiometabolic system plus mood disorder. So there will be different etiology for the different subtype. But that's just from the data from Taiwan. And we identify people who are at the current risk profile, but we do not know the incubation period. So people who are frail today, who may just have those presentations for 1 year or 10 years, but we're not able to identify, to make sure of their incubation period. So we work with Japan using Japanese NCGG cohort, NEOS LSA, that has a much longer time, so about 14 years something. So that we have the luxury to clean the data. We selected people who are robust in the beginning, who are free from all the symptoms in the beginning, and trace them for 10 years. And the result from the NEOS LSA did support our hypothesis and our findings that in the aging process, people will gradually become mobility type frailty and non-mobility type frailty. So in the nature course, it is developed like that. And those who develop with mobility frailty are having higher multimobility during the observational period. They're having more diseases, and they're having faster decline in cognitive function. So that is compatible with our observation using a much better research design. And our previous study also showed that in terms of those earlier declines in the physical conditions, if you focus people who are already frail, their cognitive performance is very impaired already. So all the domains, including memory and non-memory domains, are impaired already. But if you focus on those who are just pre-frail, and they have some cognitive deficit, but mainly on non-memory domain. So at this moment, memory is intact. So the major impairment comes from language and executive function. Another cohort from the Western country also supports that in the aging process, memory decline is relatively later compared to other dimensions. So the executive function decline appears probably the first and the earliest domain in your aging process. That is related to mobility instead of simply memory. And a recent paper in the States, they also showed that if you want to predict cognitive impairment based on the 5 items of physical frailty, it's not all the same. Only weakness, slowness, and weight loss can predict cognitive impairment, not for the others. So that also echoes our finding that mobility components are very, very important, not just for disability, but also for dementia and the cognitive impairment subsequently. So until now, we have some evidence saying that mobility is important, not just for disability. They are also important for cognition. And non-memory domains cognitive function are also important and very early sign for the declines, including language and executive function. And the cognitive function should be measured objectively instead of subjectively. So that helps us to generate the operational definition and a new proposal. So we're hoping to have a new proposal to capture the two things that at the same operational definition. So we have a lot of discussion with Professor Alai whether we should modify the definition of cognitive frailty or modify the MCRS. But that would be very, very difficult because they have already published some work and a lot of group of people are trying to continue working on that. And to avoid confusion or to generate more confusion, we decided to get a new name. Which is the Physio-Cognitive Decline Syndrome. I think that is more clearly to indicate this phenomenon is focused on the concurrent physical and cognitive declines. And we focus more on the potential reversibility. That is our main purpose. We want to change the aging trajectories. So in the two parts, one is the physical part, we call it MIND, it's mobility impairment, no disability. We use slowness and weakness. That is based on our previous data and also the finding from other cohorts. In the cognitive part, SIND, C-I-N-D, cognitive impairment, no dementia, is we take the MCI approach, that 1.5 SD of the cognitive performance for the age, sex, and education matched norms. But it covers all different dimensions, not just for the single dimension. We cover both because you can measure more dimensions so that you can get more cases because the early decline is not in memory domain. So you need to do more, the assessment for more dimensions. So in any one of them that have 1.5 SD below the mean can be the people with cognitive impairment. And we're trying to answer whether this operational definition can predict mortality, disability, and dementia. So again, we have to work together with Japan. So from Taiwan, we use two cohort studies. One is the ELAN longitudinal aging study. Another is CBUS from the government. That is a national representative cohort. Both cohorts supports that PCDS predict all-cause mortality and cardiovascular mortality. And as to the incident disability and incident dementia, that you need a bigger sample or longer observation that we do not have at this time. So our Japanese colleagues use their data to prove that PCDS eventually can predict incident dementia and incident disability. So from epidemiological studies, we know that this definition can predict incident dementia, incident disability, and mortality. So that is compatible with our primary hypothesis that this is a risk condition. But the problem is why. We want to know more about it because if you look at the MCRS study and the cognitive frailty study, they are more on epidemiology. There are much less intervention study. There are much less study focused on the etiology and the pathophysiology. So overall in the community, it can be 10 to 20% of people who are having PCDS, but what happened to them? In our ELAN cohort, we have the brain imaging. So we use the data from the MRI to explore what is the major gray matter volume deficit in the PCDS. And so we split the participant into three groups. One is the healthy, robust one, and the second, in the middle row is the middle-aged PCDS, and the lower row is the elderly PCDS. And the red dot is the gray matter deficit. With more red dots means there are more gray matter deficit. So it's interestingly that in the middle age, even though phenotypically people presented with PCDS, but there is very few significant gray matter deficit. But in the elderly one, the major deficit will be on amygdala, hippocampus, and cerebellum. But this is also, of course, this is a new finding that inspired us, but also confused us because that three regions are not really near to each other. How can people are so lucky to have three different areas getting impaired at the same time? How can it be possible? So we use the DTI technique of the MRI to identify there is a new neural circuit linking amygdala, hippocampus, and cerebellum. That makes very wonderful sense because amygdala is handling about the emotion, and hippocampus for memory, cerebellum for movement and coordination. Coordination in movement as well as in working memory. So that can explain our finding. But that's just for the morphological differences. So we're hoping to know what really happened. And so we do some cell line study and the animal study. So we found that the atrophied muscle fiber eventually can secrete a lot of things through the exosomes, and including a lot of non-coding RNA. So there's a lot of different non-coding RNA will be secreted as exosome form from the atrophied skeletal muscle fiber. But what will happen to the brain, to the neuron, when those exosomes through the circulation into the brain? So we use if you do the neuron cell line study, they usually come from the neuroblastoma. That's not a really human neuron. So we use the IPS scale, the IPS platform to generate a real human neuron. So we have the iNeuron. So we found that the microRNA secreted from the atrophied muscle, especially the miR29B3P, and when they hypothetically, through the circulation in exosome form, they go to the brain, and what the neurons will react to the microRNA, and we found that the neurons will be degenerated, and the development will be delayed, and will trigger the senescence of the neuron through especially the H1, the HIF alpha pathway. That's a very interesting, and we're now working a lot into this pathway. That is a very special pathway that the microRNA eventually triggers senescence of the neuron. So the atrophied muscle can secrete negative regulator to promote or to accelerate neuron senescence. So some kinds of changing our mindset and idea about brain and muscle interaction. Traditionally, we think brain gave orders to the muscle to contract through the CNS, PNS, and the neuromuscular junction. And how can muscle respond to those actions through the proprioception receptor and the stretch receptor in the muscle spindle? So how strong the muscle contract and how they relax, and feedback through the nervous system to the brain. That is how we learn from physiology and neuroanatomy. But now we found there is a pathway that through the circulation, there will be a negative regulator from muscle to brain, not through the nervous system. There may be some other molecules secreted by brain through the circulation to muscle. So there may be a new brain-muscle axis not going through the circulation instead of the nervous system. So the PCDS, now we're in the pathophysiology and etiology, we're now working hard on that specific pathway, trying to find out what's the really linkage between the two. And I'm not going to talk too much about the multi-domain intervention because the studies have shown from the finger study, we know the multi-domain intervention eventually can prevent frailty and dementia at the same time. So it should be effective to PCDS as well. Then there will be some other speakers to talk about that. And I'm going to show you how we're going to do it. Now we're going to implement those interventions in the community. So we have in the place I'm working in the community, we had opened 2 new community sites to get all those multi-domain interventions at the same time. And this is how it's going to look like. And we're going to implement the TIGER program. I think Wei Ru is going to do his report later on. That TIGER is a recent published paper in Lancet Health and Longevity of the multi-domain intervention programs. And the 2 sites will all both implement the TIGER study. And we're also trying to do something more because we want to have a sustainable mechanism that healthy longevity and healthy aging is the needs to continue of those multi-domain intervention can be decades. You have to do it all the time. But how can you not feeling bored by those interventions? So many studies and many interventions are trying to do the gamification, make things like a game to increase your fun and pleasure by participating in the program. So there are some evidence supporting this gamification, that playing video games can help you relatively increase the volume of hippocampus and cerebellum. Again, hippocampus and cerebellum, that is exactly the region we just found in the PCDS. That study published by McGill, they found that only playing the Mario through this with 3D feelings, not the traditional 2D video games, that can help you relatively increase the volume of hippocampus and cerebellum. Yeah, Mario is in the air. The computer is down. Okay, so there are some other games we're trying to working on this. So with those evidence, we do some randomized control trial of the video game health promotion intervention, playing by the mahjong and the dancing machine. And a very, very new data, we just had a result yesterday, that they both improve in the cognitive function and in the brain MRI and the brain age as well. So there's a very good intervention that is effective, not just a game, it is an effective intervention. And now we're also combining, because the very early cognitive decline can be in the visual spatial function. So now we're also doing the VR games, using the VR to detect the early visual spatial deficit and to train, because those dimensions is trainable. So now we're hoping that to introduce multimodal of intervention to the multi-domain intervention to make the things more sustainable. You feel fun and having pleasure, so that you will be happy to continue doing it. Not, feeling being it's kind of obligation to promote your health. It's just for fun and pleasure that can be very, very effective. So this is about to end my talk, that from the phenomena and conceptual frameworks, and through the epidemiology and the pathophysiology from the basic aging molecular study and imaging study, we did find that PCDS should be a special entity in the healthy aging or the healthy longevity. Especially, some studies in our group, we found that PCDS then become dementia. They seems differ from the traditional Alzheimer pathway, because in the trajectory of the developing the cognitive impairment, mobility has a very, very strong role, but not the memory. So this may be a subtype or another pathway to develop the cognitive impairment or even to dementia. So, but this phenomenon is important that they can highlight. We try to identify people who are at risk for two major adverse events in your later life, and then we can provide intervention to cover the two things at the same time. So that is the major idea, and the past few years work to define the PCDS from phenotype to pathophysiology, and we're hoping that we can have better evidence to generate some new biomarkers or even specific treatment in the future. Thank you very much.
Thank you, Liang for your nice summary on PCDS and also the insight on the interaction between brain and physical function. Okay, let's move on to the next speaker, Dr. Su Zhang from National Center for Geriatric Gerontology, Japan. The title of our talk is Epidemiology of PCDS and Participant of the NIDS LSA project. So let's welcome Dr. Zhang.
Sorry, I forget to open my mic, and I will share my PowerPoint again. Okay, can you hear me?
Yes, yes.
Okay. Thank you, Professor Alai. Good morning, everyone. I appreciate.
Excuse me, Professor.
Yeah?
Your camera didn't turn on.
Okay.
You can turn
Thank you,
on the
Professor
camera.
Alai.
Turn
Good
on the
morning.
camera?
I turned on my camera.
Yes, yes.
Ah,
Please.
sorry.
Yes. And share the screen. Yes.
Okay. So thank you, Professor Alai. Good morning, everyone. I appreciate the opportunity to speak today and shall be offering a brief overview of PCDS epidemiology in News ELSA project participants. As shown here, first I will be introducing background material on the News ELSA project and the NCGG SGS cohort in Japan. Subsequently, I will present a comparison of the epidemiology of PCDS in these two projects and then briefly discuss the association between PCDS and health outcomes. Next, I will discuss the current epidemiological view along with a new definition, the mind saint, and finally, I will discuss some preliminary results for the association between mind saint and serum biomarkers. The News ELSA project was initiated and longitudinally conducted by the NCGG Center, which was formerly known as the National Institute for Longevity Sciences. The primary purpose of the News ELSA project is to systematically observe and describe the normal aging process in humans. The project is also attempting to identify factors associated with longevity, aging, and geriatric diseases. Sex and age stratified community dwellers living in the Obu and Higashiura were randomly selected and included in the study. The News ELSA baseline examination evaluated men and women aged 40 to 79 years. During the first wave study, participants visiting the NCGG were asked to complete aging and geriatric disease surveys. Factors examined included medicine, physiology, nutrition, and psychology. This slide presents results from the sixth wave survey data analysis. As seen in this slide, the NCGG SGS cohort, which is a Japanese national cohort study, also generated some important results. The primary goal of NCGG SGS was to establish a screening system for geriatric syndromes and validate evidence-based preventive interventions. Each of the individuals was recruited from either Nagoya or Obu, with participants from Obu aged 65 years or older and those from Nagoya aged 70 years or older at the time of the baseline examination. A total of 971 older participants were examined in the News ELSA sixth wave analysis. Participants with a MMSE score under and equal to 23 or who with a self-reported history of dementia were excluded from the analysis. Participants with incomplete data were additionally excluded. Thus, this study analyzed the data from 833 older adults. The MMSE subtask definitions are consistent with the definitions used in the Taiwan's cohort. Subtask 1 to subtask 6 measures the spatial and temporal orientation, short-term memory and calculation, delayed recall, verbal comprehension, imitation, and constructional praxis, respectively. Cognitive impairment was also defined by using the Weiss RSF and the reverse digit span test. The Weiss RSF examines information, similarities, picture completion, and digit symbol coding. Information test examines basic knowledge of society and natural phenomena. For similarities, participants need to answer a question like how dogs and lions are similar. For picture completion, participants are given an incomplete picture and then asked to point out which part of the picture is missing. For digit symbol coding, participants are asked to fill the symbols corresponding to the number of numbers in accordance with the given rules. And for reverse digit span, participants need to repeat the numbers dictated by the staff in reverse order. As seen in this slide, two kinds of PCDS are possible, with both having the same physical impairment definitions. The definition is based on a grip strength less than 28 kg for men and less than 18 kg for women, or a walking speed less than 1 meter per second. For PCDS1, MMSE for any subtest was less than min minus 1.5 SD, while for PCDS2, we used Weiss RSF with any subtest less than min minus 1.5 SD, or reverse digit span less than min minus 1.5 SD to define cognitive impairment. This cross table showed that there were more participants in the PCDS1 group than in the PCDS2 group. The epidemiology of PCDS in the NCGG-SGS cohort is seen in the next slide. Two different cognition tests were used to define the cognitive impairment, as seen here and similar to that used in the news ELSA. MMSE was the first test. As seen in this slide, the second test was the NCGG-FAT, which is a multifaceted application that was developed by the NCGG for evaluating cognitive functions and assisting in the early detection of the risk of mild cognitive impairment. The application is available in the Apple Store. The four subtests assess memory, attention, executive function, and processing speed. Performance of memory and processing speed are expressed as scores, while performance of attention and executive function are expressed in time. There are also two kinds of PCDS, and which have the same definition of physical impairment. However, cognitive impairment was defined for PCDS3 as MMSE any subtest less than min minus 1.5 SD, and for PCDS4 as NCGG FAT any subtest less than min minus 1.5 SD score, or more than min plus 1.5 SD time. As seen here, Table 1 shows the frequency of PCDS prevalence in news ELSA participants, while Table 2 shows the frequencies of PCDS prevalence in the NCGG-SGS participants. Results show prevalence increased with age and was higher in women versus men. Interestingly, PCDS defined when using MMSE subtest to measure cognitive impairment resulted in a higher prevalence compared to PCDS defined by using other tests to measure cognitive impairment. This slide shows the participants' characteristics determined by PCDS-1 and the PCDS-2 status when using the News ELSA data. Overall, similar differences are observed between participants with PCDS and without PCDS. However, participants with PCDS-1 are less likely to be married, while PCDS-2 participants are more likely to have knee arthropathy and depressive symptoms, and less likely to be men and a current smoker. As per the results shown in Table 5 and 6, similar differences between participants with PCDS and without PCDS are found using NCGG-SGS data. The only exception was that PCDS3 participants were more likely to have diabetes. With regard to the association between PCDS and health outcomes, as seen in this slide, we used the same News ELSA data. In this analysis, we additionally excluded participants with disability at baseline. We initially focused on the incident disability, which was defined as having a LTCI certificate. The LTCI is a mandatory national social insurance plan designed to assist older disabled individuals in carrying out routine daily activities. Results suggested that PDS-1, which is defined by physical impairment and a low MMSE score, performed better in predicting the incident disability compared to the PCDS-2, which is defined by physical impairment and a low WAIS-SF score or low digit span score. And the low MMSE score was only related to disability in women. Similar results were also observed for the mortality prediction. However, a low MMSE score did not appear to be related to mortality in the News ELSA participants. A positive association was also observed between PCDS-1 and incident dementia, with physical impairment related to incident dementia in men, while in women the low MMSE score was related to incident dementia. The MMSE subtest scores are not normally distributed. Thus, during the analysis, when using a mean minus 1.5 SD to calculate a cutoff point, a large variation results in a negative number. Moreover, for the MMSE subtest 5, which only has two values of 0 and 1, this means that the use of a mean minus 1.5 SD to calculate a cutoff point might not be appropriate. Therefore, prior to determining the definition of PCDS, we adopted an alternative concept, namely mind-sync, as a way to alternatively explore biomarkers that could be used to identify PCDS. Mind-sync was defined as having grip strength or walking speed less than their sex-specific 20th percentile cutoff, plus having a total MMSE score that was less than the median value of all participants. We also created a control group by defining it as having both grip strength and walking speed that was more than their sex-specific 80th percentile cutoff, plus having a total MMSE score more than and equal to the median value of all participants. This slide shows the cutoff points. If you focus on the bold numbers, you can see that even the 20th percentile cutoff values for grip strength and walking speed were better than the criteria that we used to define the PCDS. Furthermore, the median value of total MMSE score was also quite high, which can perhaps be attributed to the good overall health status of our participants. This table shows the number of participants for the mind-sync and the control group. Since the control group number based on our original definition was too small, we decided to use either the grip strength or walking speed that was more than their sex-specific 80th percentile cutoff, in addition to have a total MMSE score that was more than or equal to the median value as the controls. The graphs on the following two slides show distributions of the serum biomarkers for men and women. As there were some outliers, which could be a problem, as seen in the next slide, we decided to exclude any outliers prior to performing our analysis. As seen in Table 7, which presents the characteristics of participants, we can see that the mind-sync group participants tended to be older, to have less education, to have a stroke history, and to be a current smoker. In contrast, they were less likely to be married. However, overall, there were no obvious differences observed for the serum biomarkers between the mind-sync and the control groups. After full adjustment for all of the factors, only creatinine was found to have a higher level in the control group. A previous study in an older Japanese population reported that having above normal serum creatinine levels had a negative association with the physical aspect of frailty, which could be due to the aging process, as this value is closely related to the muscle mass. As we come to the end of my presentation, let me summarize the key points once again. This presentation reported on the News ELSA project and the NCGG-SGS cohort in Japan. A comparison of the PCDS epidemiology in these two projects found that the epidemiology of PCDS was comparable to some extent. Furthermore, an evaluation of the association between PCDS and health outcomes indicate that PCDS may be a good predictor for disability, mortality, and especially dementia in our study population. Subsequently, I discussed the current views on the epidemiology of mind-sync, and finally, also a preliminary analysis of the association between mind-sync and the serum biomarkers was undertaken. Only creatinine was found to be significant, with only a small regression coefficient. Therefore, further analysis using other surveys that contain more biomarker data will be needed in order to explore potential novel indicators for the prediction of PCDS. I'd like to express gratitude to Dr. Shimada, Dr. Doi, Dr. Lee, Dr. Tange, Dr. Tomida, and other researchers for their support in this data analysis. Thank you very much for your attention.
Thank you very much, Stu, for a nice presentation. Now we are open for discussion. We have a couple of questions from the audience. The first, let me introduce the first question from Michelle. The question is for Liang about the serum biomarker linking muscle to brain. Are there any other possible biomarkers under investigation in addition to microRNA you just mentioned? And also, is it possible to develop serum diagnostic tool and even treatment based on these findings? So, any comment?
Yes, now we're doing some studies. The first thing is we use the cell model and the animal model to identify potential biomarker that links muscle atrophy and potential neural senescence. So another challenge is the intervention effect. We're hoping that through the intervention, we can find that the biomarkers also changes with the intervention that has been shown to be effective. So nowadays, we're Dr. Peng Lili and Dr. Li Weiru, they are working on a brain project that is an intervention-based study. That through the more frequent multi-domain intervention, because our previous intervention, the frequency is not very high, so some benefit of the physical performance gradually decays after the first few months. So this time we had just started an intervention trial with more frequent, higher frequency of the multi-domain intervention. And this time, not just measuring the phenotypic changes and the questionnaire-based things. This time we will measure the biomarkers and the brain images. So we're hoping that we can establish more strong evidence that the miR29B3P can be an effective biomarker and also predict the subsequent changes in the PCDS. If so, then we can have a biomarker. But as to the therapeutic target, it may be not, because the miR29B, now we don't know how to really suppress the excretion only through the exercise, through preventing the muscle atrophy. But we still don't know how to antagonize the work of miR29B3P. But maybe in the future, we are able to have some antagonist or to suppress the secretion of miR29B and other negative regulators. So the quick answer is yes. I think there is a potential to develop the diagnostic and the therapeutic platform for PCDS using those biomarkers. Thank you.
Thank you. Sorry, this is a question from An Chun, not Michelle, sorry. The next question is for Michelle, and it's also for Liang Gong. From current research, how long does it take from the video game to improve the cognitive function? Can you suggest an appropriate observation period?
So far, 6 months. That the paper from McGill, they played the video games for 6 months. 6 months. And in our trial, we just recently started to wrap up the data analysis, but the quality of the data is not very good because of the COVID-19. It is a community-based intervention. So due to the pandemic, a lot of activity is being suspended. So we are not able to have very precise measurement and intervention protocol followed as previously designed. But our current finding is that through 6 months of video game interventions, either mahjong or the dancing machine, there are some improvement in the neuropsychological test. Even though they play for 6 months and being suspended for 3 months, So some of them are eventually they stop the intervention for 3 to 6 months. Even though they stop the intervention, still the neuropsychological test remained improved. And as to the brain imaging findings, so far that's very, very interesting that for the dancing group, there are some improvement in the gray matter volume of cerebellum. But for Mahjong, no. Mahjong, the improvement of Mahjong is more on insula. Insula is the function of an insula is to create your happiness, enjoyment, engagement, and addiction. So maybe, yeah, it shows the nature of the people are more, very happily involved in the video games. But until now, at least we know that maybe Mahjong really created happiness and engagement of activity, but does not really change the cerebellum. But those with physical activities, especially more complex dancing exercise, can really improve the coordination and potentially prevent physical frailty and cognitive impairment. So maybe exercise is still needed. Otherwise, through the metaverse, everybody will get the limbs shrinked. So yes, the answer is 6 months so far based on the available evidence. But a lot of more things need to be checked in the future.
Thank you. I'm afraid the function of insula and amygdala is impaired during the pandemic for stay-home policy. And I'm just kind of, I'm related to this question. I'm interested in the 3D VR in addition to physical exercise. So if you do physical exercise at the same time with VR game, that will enhance the cognitive stimulation. What do you think about it?
It may be possible, but still need more study, because studies has shown that if you're really physically seeing an object through your eyes, I mean through the real eyes, compared to seeing that object using VR, your brain area was not activated at the same region. So that conceptual thing can eventually, I think there'll be different effect on the VR-based video game. But there's one thing that is potentially optimistic, is that because visual spatial deficit is very early biomarker for cognitive decline, so we are hoping that VR may be able to detect early impairment in the visual spatial function and train. But so far, no evidence at all. So
yes.
We are preparing some trial doing it in the future.
Yes, that will be our future. I think we can do assessment and intervention at the same time with the VR system, in addition to physical exercise. Okay, there are 2 other questions to Dr. Zhang. One is from Michelle Tang, probably. So what messages will you give to clinicians in identified MIND, MIND, SIND cases in practice? So Dr. Zhang, can you answer the question?
So
It's a clinical question.
Yeah, clinical question. Until now, we just did the preliminary analysis for the biomarkers, and because we only have limited serum biomarkers in our 60th wave survey, and we did not find any very interesting differences between the mind-SIND and the control group. So and another question is that our participants is relatively healthy than participants maybe in Taiwan. So it's a little difficult to find the differences between the mind-SIND and the control. But next, we want to use other survey data like 7th or the 9th with more biomarkers to identify the difference between the mind-SIND. But unfortunately, until now, maybe we could not give any advice or something for the clinical practice to identify mind-SIND. Yeah, I think so.
Yeah, I can answer.
Yeah.
I will bring the participant or patient with mind-seen cases to multimodal intervention, like finger or tiger or jamming style. So that would be my message, but it's not socially implemented. I mean, the jamming or finger multimodal intervention are not still socially implemented. So it's still hard to make intervention for these patients. The other question is from Liang Yu Chen from Taipei. Lymphopenia was an indicator for adverse health outcomes. Is there any information provided on lymphocyte count in this study? Any data about lymphocyte count?
Lymphocyte count, I think we don't have this kind of data in the six wave survey because due to the limited foundation or something, but we have lymphocyte data on other surveys, so maybe we could check it later, I think. Yeah.
Okay. There any question, Dango?
May I ask a question to Dr. Zhang?
Yeah.
Because the current approach we're taking for the mind-seeing versus the healthy control, they are, at least in the physical component, there are two very extreme cases. One is 80th percentile, another is 20th percentile. So theoretically, they should be very, very different in phenotype already. But how are you going to provide appropriate explanation there? How come their biomarkers are almost identical for two phenotypically very different group? Do you have some more potential explanation or reasons?
Yeah, and in my opinion, the lowest 20% cutoff for our participants is also quite high or just similar to the normal population, and even these two groups presents two extremely different population, but I think some biomarkers in the population, which I think represents the level equal to or a bit over the normal population, would not increase linearly, I think, in my opinion. So we could not find a very obvious differences between these two groups.
The current approach is a relative comparison. So the best, the 80th percentile versus the worst, the 20th percentile. So based on your finding and your speculation that you think most of the participants of the NEOS LSA are, if there is physiological, if there is a cutoff, a natural physiological cutoff to define PCDS, so you are suggesting that most of the participants from the NEOS LSA are above the threshold, are very healthy. So basically, there will be, through the biomarkers perspective, there will be very, very few cases of PCDS in your cohort. Is that your idea too?
So I'm sorry.
Maybe. Yeah, I can answer. Yeah, maybe that might be a question answer, but another explanation would be all the biomarkers we studied are not relevant to the difference between PCDS and normal control, and also not so sensitive enough to detect the difference in the sample size. So we need new biomarkers to identify the difference between the two conditions. Did that answer your question? Yep.
Thank you.
Okay. It's about time to close the symposium. Thank you very much for your active participation. We are going to take a break after the symposium and take a photo, maybe.
Take a photo.
So, yep. Group photo.
感谢两位讲者为我们带来精彩的演讲，谢谢 Professor Lai， 感谢各位踊跃的提问发言。现在是大合照时间，有请所有讲者及贵宾来到台前合影留念。Thanks for all the professors given us the wonderful speeches. Thank you, Professor Lai. Thank you all for your participation and comments. Now sincerely invited all speakers come to the stage to have a group photo. 合照。Cheese.
Oh, Shika is in Kaohsiung? Not in Taipei or Hsinchu?
好了吗？ One more time. Okay. Thank you.
Thank you, thank you.
各位来宾，现在是茶休时间，场外备有茶点，欢迎各位享用。下一场演讲将于10点40开始。Thanks for your participation and cooperation. The next session will start at 10:40. Thank you. 各位来宾，大家早安，欢迎回到身智衰退症国际研讨会。接下来有请台北市立关渡医院陈亮公院长为我们主持。Good morning, ladies and gentlemen. Let's welcome Professor Liang Gongchen, the Superintendent of Taipei Municipal Gandao Hospital, to host the following session.
Thank you, and good morning, everybody. Now we'll move to the second session. Today there will be many speakers doing their research, going to report the result of the PCDS. So the first one will be Dr. Zhuang Shaoyuan, who is the Associate Researcher of the Institute of Population Health from the National Health Research Institute, using the cohort data of host to present the result regarding to the clinical characteristic of physio-cognitive decline syndrome and inflammatory markers. And so let's welcome Dr. Zhuang for his wonderful work.
Thank you, Professor Chen. And I'm Shaoyuan Zhuang. I'm from the Institute of Population Health Science and at National Health Research Institute in Taiwan. This is my topic, clinical characteristic of physical cognitive decline syndrome and information markers. Previous study has reported that chronic inflammation associated with development of dementia, and the information marker also with physical impairment function. So physical cognitive decline symptom is the pre-stage of the dementia and disabled. So we think that information may be an early marker for development of PCDS. So in this study, we have a hypothesis that information marker may be the precursor of the PCDS. So in this study, we aim to investigate the association between information and the PCDS. We also describe the clinical characteristics among the elderly with PCDS. We use the health agent longitudinal study in Taiwan to investigate the association between inflammatory and the PCDS. This study include 7 study sites in local hospitals, and this study in the baseline enroll 56 and 63 elderly aged more than 50 years old to complete the household interview, and 53 and 68 elderly complete the physical examination. And the baseline wave is at 2008. This is the characteristic of the participant. About more than 70% are aged more than 65 years old, and 22% with women, and only more than 55% their education is non-education or primary school. So this is our population identification. So we identify the age more than 65 years old is elderly, and we exclude they may have dementia, and the criteria is their education year more than 6 years, and their MMSE less than 24, or if their education year less than 6, and their MMSE less than 14. Then we also exclude 4 subjects without walking speed or hand grip. So this is finally we have 34 and 91 elderly, more than 65 years old, and without dementia. So we define the physical-cognitive decline. The elderly must be fit, both physical decline and the cognitive decline. Then will be identify the physical or cognitive decline syndrome. The physical decline, we include slowness or weakness. Slowness, the criteria is walking speed less than 10 meters per second. Weakness, the hand grip less than 28 kilogram for men and less than 18 kilogram for women. Cognitive decline, we define that more than 1 MMSE subset abnormality. Okay. So this is the proportion of combination of slowness and weakness. And in this population, we can find that 70% is slowness and 42% is weakness. And we can find a yellow group is slowness, but weakness, don't have weakness. And the group, red group is slowness combined weakness. Only 3% group is slowness, no slowness but weakness. So if we combine slowness over weakness, and more than 80% with slowness or weakness. So in this population, the slowness or weakness is a majority, high population, high prevalence. And we, to identify the proportion of the estimate the proportion of each MMSE subset, this lend the lower 1 point standard deviation among elderly subjects without dementia. And we have 6 subsets. One is temporal, orientation, and spatial. And this, in this category, in this subset, the percentage is about 8.6. Another is immediate memory and the calculation is about 9%. Memory and delayed recall is 7%. Verbal and comprehension is about 5%. Constructional paradox is more than 10.8%. This number is okay. This number is about how many score in this subset. So we combine the slowness or weakness and the cognitive decline subset, and we can find that this red box is physical decline, includes slowness or weakness, and we can find that most population with only one MMSE subset abnormal, and we can find that the elderly combined slowness and weakness had higher proportion for cognitive subset abnormal, about 44%. Okay. So finally, we have used the criteria to identify 25.8 population with physical PCDS. So in this population, about 1 in 4 elderly have 1 elderly with PCDS. So this is the characteristic of the population with PCDS, and we can find that PCDS has few male gender, and old age, and lower body height, and lower body weight, but their BMI is not difference between PCDS and with and without PCDS, and we also can find that the PCDS elderly has lower schooling year, and low MMSE score, and they had lower hand grip and lower walking speed, because this is follow our define to identify the PCDS. And this is the clinical characteristic of physical cognition decline symptom. And we can find that PCDS elderly had higher hypertension proportion. And but the proportion in diabetes, heart disease, stroke, dyslipidemia, asthma, respiratory disease has no significant difference. And we also can find that PCDS had lower cancer history. I think that maybe it's a survival effect if the severe cancer elderly maybe not mortality early, death early, so they not participate in this study. Okay. And this is another, and we can also find that cataract had a higher proportion in PCDS. And we can find that renal disease and osteoporosis disease is higher. It's lower than PCDS. And I guess this because PCDS has higher woman proportion, and those two disease is generally is higher prevalence in women. So we can find that renal disease and osteoporosis and lower in this population. Okay, so we also to investigate the frailty and the association between frailty and PCDS, and we define the frailty is weight loss. If the elderly, they report they have unintended to weight loss more than 4.5 kilo in this year. Exhaustion, we use the PCDS to define the exhaustion, and we also use the define low physical activity. We identify the lowest gender and specific 20% of study population. And the slowness, we use the walking test, 3 or 4 meters. And we classify the criteria is also age and BMI specific, and weakness. Okay. So we can find that PCDS has higher, PCDS population had frailty population had higher PCDS proportion, about 50%. And we can find that robust has lowest PCDS. It's linear dose response relationship. Okay. We, in order to identify the more early marker about the PCDS, so we design a case control study to identify the spectrum of PCDS, the two-tier spectrum of TTBS. So we identify the case is walking speed less than 0.7 per second, 0. meter per second, and the weakness, and any MMSE subset abnormal. This is the case. This is a case group, and we also identify the control group. Walk speed is more than 0.9 meter per second, and weakness. They don't have weakness. They don't have weakness, and their work strength is more than 28 for men, and 18 for women. And they also have all MMC subset is normal. So these two groups is the spectrum of PCDS two tiles, and we match their age and gender, and we identify 195 pairs. Their age and sex was matched. And this is the result, and we can find that even we match the age, and we can find that PCDS case group is higher propensity to PCDS, and they has higher age. But age, gender we have matched, so the gender proportion is the similar into these two groups. And we can also find that case group has lower hand grip and lower work speed and lower MMC score and lower education. But their BMI is not significant difference. But we can find that the case group has wider waist circumference. This is a central obesity indicator. Okay. And we can find that when we control the age, and we don't find the hypertension prevalence is no difference between case and the control group. But we find that diabetes, the case group has significantly higher diabetes prevalence. Prevalence is prevalence of 28.7 versus 12. And we can also find that stroke history is higher in case group. And we find that cancer history is lower in case group. Okay. Others clinical characteristics and have no significant difference between these two groups. And if we and the other gout, anemia, renal disease, arthritis, osteoporosis, mental disease, or Parkinson's disease is no significant difference between these two groups. So this is the cardiometabolic disorder in elderly with and without PCDS, and we can find that pulse pressure in PCDS has higher pulse pressure and higher insulin level and HOMA, IR index, and higher fasting glucose and higher HbA1c. So those two groups indicate the diabetes or glucose control. And we can find that total cholesterol or triglyceride, HDL, LDL, no significant difference between these two groups. And this is renal function and the liver function about the two groups. And we find that PCDS group has higher BUN and higher uric acid and higher GOT, GPT. This is two liver function score indicator. And we can also find that grouping and the total protein is higher in PCDS group. And this is a primary inflammatory marker for PCDS, and we can find that the PCDS elderly has higher level in high sensitive CRP and high level in TNF-alpha-1 and high sensitive in interleukin-6, and others such as fibrinogen or interleukin ILGRF or ILSR, no have difference between these two groups. Finally, we try to, because the clinical characteristic or the renal function marker or liver function marker or inflammatory marker are correlate. So we try to identify the independent marker to identify the PCDS population, elderly. So we conduct a independent multiple linear logic regression, and we identify age, total protein, heightened CRP, and heightened interleukin-6 and diabetes as positive associated with the PCDS. And okay, so in this study, we the PCDS prevalence, our PCD prevalence is higher than previous study. Is Taiwan Health Promotion Intervention Study for elderly. This study report PCDS about 18.9%, but our study report the PCDS is 25%. So we can find that our mobile frailty is higher, is very high. This number is, I need to correct this number. This number is 30. This number is 30. So in our study, host study, our cognitive dysfunction is higher, and our mobile frailty is higher. So our prevalence is higher than previous studies. Even our age is younger than the Taiwan Health Promotion Intervention Study for elderly. So we try to identify why our population, the PCDS prevalence is so higher than other studies. We try to identify this reason. So we try to reverse over the walking speed criteria. So the green bar is the currently PCDS prevalence slowness, but we try to identify this to find that if we lower the walking speed to 0.08 and the abnormal, the slowness in our population from 81 to 50. And about the PCDS prevalence, and we can find that if we lower the walking speed to 0.8, and the prevalence is similar to other studies. So we also to find out potential reason. We find that our walking speed measure is stand up than walk. So maybe the operation define is different with other studies. And in our study, we also find high total protein is associated with PCDS, and elevated total protein may indicate inflammation or infection. And in our study, we also can find that higher total protein is associated with positive associated with heightened interleukin-6 and heightened CRP. And in the PCDS population, it's higher, significantly higher total protein prevalence. Okay, and inflammation marker is associated with physical impairment function. In our previous study in host was show a similar result, and this study is by Dr. Wu and Dr. Xiong, and they use the factor analysis to identify two factors. One factor is CRP related, two factors TNF-alpha related, and these two factors also identify heightened CRP and interleukin-6. And this study find that if the elderly, the subject with higher severe quartile, and they have higher risk for functional impairment. Okay. And this is another study from US, and they use the National Health and Nutrition Examination Survey to find that insulin resistance is associated with gas speed. They find that the higher the severe insulin resistance, their gas speed is 22 lower. 22 is low. And another study showed that this is a National Institute for Longevity Science study. They find that the HbA1c is about the glucose control. Is associated with information processing speed. This study followed 10 years and can find that if the diabetes elderly with glucose control well is their HbA1c less than 5.6%. They have slow speed for decreasing in information processing speed, and this observation in both men and women. And meta-analysis also have shown that peripheral inflammatory marker is associated with dementia, and this study include 5 studies, and to show that if the elderly has higher inflammatory markers, they may include about 4.54% risk. And in our study, study was carried out in the National and Health Survey in Taiwan for elderly. This study also demonstrated that high CRP has higher dementia incidence in all type dementia. Okay. So we have a conclusion that in this study, the prevalence of Physio-Cognitive decline symptom is 25%, and the slow weakness most contribution the high prevalence of PCDS in whole study. And we identify the diabetes, high protein, and high sense CRP, and high sense interleukin 6 associated with PCDS. And we identify these 4 marker. They had indicator about information, and we also find that diabetes also is a disease highly rated information. Okay, thank you.
Thank you, Dr. Zhuang. So we'll have discussion later after the session. And so our second speaker is Dr. Liang Zhiguang, who is now in Kaohsiung. And he's going to share part of his work related to the clinical efficacy of multi-domain intervention on PCDS. Dr. Liang is the chief, division chief of the Division Geriatric Medicine of Kaohsiung Veteran General Hospital, and also the assistant professor in National Yangming Jiaotong University. And so let's welcome Dr. Liang from Kaohsiung.
Okay, thanks for Professor Chen's introduction. I'm Dr. Liang. I'm from the Kaohsiung Veteran General Hospital. I'm appreciated the opportunity to be here with you to share my research about the clinical efficacy of multi-domain intervention on PCDS. These results are from a clustered randomized control trial. According to previous research, we can see that there are several risk factors that may increase the risk of dementia in older population. These risk factors included sensory disturbance, chronic disease, mood, and physical activity, and learning and education level. In general, the older adults usually have multiple risk factors at the same time, not just one risk factor. So if we only focus on a single risk factor, the intervention may be not effective. And this year, the European Task Force for Brain Health Service Working Group published a series of consensus on improving the investigation, care, and the prevention of dementia. Regarding the prevention of dementia, they pointed out that the target population is not all older adults, but the persons at risk. And it's best to start intervention to reduce risk as early as possible. In addition, they tend to recommend the use of multi-domain intervention for multiple risk factors. Finally, due to the importance of the social component, the intervention should include group sections and all group activities. Therefore, we can see that multi-domain intervention may be a common strategy to reduce the risk of dementia in the near future. Finger study is a well-known large-scale population cohort study aimed at investigating the effectiveness of multi-domain intervention on cognitive function in Finland. They recruit 1,260 community old adults at risk. They use the CAT scores to assess the risk of dementia. They also include only those subjects with early and mild cognitive dysfunction, but without dementia. The MMSE is around 21 to 26. And their 2 years multi-domain intervention include the nutritional counseling, exercise training, cognitive training, and the cognitive stimulation, and also social activities. They also provide intensive to control their metabolic syndrome and the severe risk factors. The exercise training was guided by physiotherapists at sports centers, and the nurse and physicians also visit participants regularly to control their cardiovascular risk factor tightly. After 2 years of intervention, the result of finger studies showed that the overall cognitive function of the older adults at risk has improved by 25% overall, and the executive function and the processing speed have also been improved. MAP is another multi-center randomized control trial that recruited 1,680 older adults aged 70 or over. The target population is persons at risk. For example, slow gait speed, subjective memory complaints, or a limitation of one IADL. And they include the persons with dementia or MMSE below 24 and the dependents. They also, their multi-domain intervention also include cognitive and the physical training, nutritional advice, and the preventive consultation. But because they enrolled subjects with relatively better cognitive function compared with the finger study, MAP did not present the effect of multi-domain intervention on cognitive decline, muscle strength, intrinsic capacity, and variety over 3 years. However, when they focus on persons at the risk of dementia, such as persons with CAT score higher than or equal to 6, or they have a positive amyloid status, MAP could improve global cognitive function in the subdomain of orientation and delayed recall domain. From the above evidence, current multi-domain interventions usually include exercise program, cognitive stimulation and training, nutritional counseling, and chronic disease management. And also group sections are also necessary and used to increase their social component. In Taiwan, we also have our population-based multi-domain intervention study. The Taiwan Health Intervention Study on community-driven elders was designed by Professor Liang Chen. CIS enrolled more than 1,000 older community-driven persons. Similar to the results of the FINGO study, it was found that multi-domain intervention can improve global cognition and the subdomains, for example, delayed recall and the concentration functions. Although the only borderline significance was noted. In addition, fertility score was also improved after 12 months of interventions. From the talk in this morning, you can know PCDS is a potential problem related to instant dementia and disability. And the PCDS includes enough target population with reversible potential. However, there is still a lack of evidence to support the effect of multi-domain intervention on persons with PCDS. So in this study, we used a secondary sub-analysis to assess the effect of a 12-month community group multi-domain intervention on cognitive and physical decline in community-journey older adults with PCDS. And we also evaluated the subgroup of older adults with cognitive dysfunction, mobility type 30, or neither. Next, I will talk about the method of this study. This is a 4-year multi-center clustered randomized controlled trial aimed at investigating the effect of community-based multi-domain intervention on clinical outcomes. We recruit older adults from both urban and rural sites across 5 cities and countries in Taiwan. If they meet at least one of the following presentation: cerebral memory impairment, loss at least 1 IADL, or their gait speed less than 1 meter per second. And all subjects can need to participate in all training programs. We exclude the participants with dementia, dependent on ADL, or their life expectancy less than 6 months. All lived in institute, and if they have major depression or have a severe hearing or visual impairment. All participants were randomized into intervention or control group. In control group, all subjects received traditional health promotion programs in local community. And we also provided interval phone calls with healthy consultations. I will introduce the intervention programs later. And for both groups, we assess cognitive and physical outcomes of all participants at 6 and 12 months after starting the programs. The study interval is 12 months, and each session is 2 hours, including cognitive training for 60 minutes, physical training for 45 minutes, and 15 minutes of diet advice. In the first month, we provide 4 sessions, and then in the second month, we provide 2 sessions. After the third month, they only received 1 session per month to maintain the intervention effect. We also provide additional chronic disease prevention classes. In addition, all assessors and trainers receive standardized training program and materials. In terms of intervention programs, in cognitive training, we provide group activities for reasoning and memory training, such as understanding text or number rules or memory strategy and methods. In terms of exercise training, all participants in the intervention group receive strength, balance, and stretch training. Participants also received lessons on successful aging, dementia, osteoporosis, sarcopenia, and how to control their vascular risk factors. In terms of dietary recommendation, we refer to Taiwan's national nutritional recommendations and provide Mediterranean diet principle. We also provide health education and health diet advice. This slide presents the data we collect in this study. We include demographic data and self-reported disease, nutritional status based on M&A short form, and we evaluate their depressive symptoms according to the GTS-5. And we also measure their 6-meter walk speed and hand grip strength, and record their amount of physical activities. MOCA is a common tool to screen cognitive performance, and we can evaluate many subdomains of cognitive function, for example, visual, spatial, executive function, naming, concentration, language, abstract thinking, delayed memory recall, and orientation. Those participants with MOCA score below 18 were excluded from the final analysis because they may have possibility of dementia diagnosis. At the beginning, 1,442 subjects were enrolled, but we exclude 306 subjects who declined to participate. And also for exclude those persons with obviously overall cognitive impairment. So finally, the case number will further decrease to 733. PCDS was defined as the mobility deficit of physical frailty concurrent with cognitive dysfunction for older people without dementia. The cutoff for slowness and weakness was based on AWG's 2019 consensus. Cognitive dysfunction was defined as the score of any MOCA subdomain less than and equal to 1.5 times standard deviation, adjusting age and education in the same population. All cases were classified into 4 groups: PCDS, cognitive dysfunction without mobility type frailty, mobility type frailty without cognitive dysfunction, and normal groups. This slide presents the case numbers in each group. The number of cases in the PCDS is 205, and for cognitive dysfunction, the case number is 110. About the mobility type frailty, the case number is 224. In the normal group, the case number is 194. Next slide will report the results of this study. This slide shows the basic information of participants and under each condition. There are still some differences between the intervention and the control group. In the PCDS group, the female prevalence in the intervention group is high, and the prevalence of a smoker and the subject living in rural area was high in the control group. In the group of cognitive dysfunction, there are no significant differences between control and the intervention groups. In the group of mobility type frailty, subjects in the intervention group had higher BMI. Finally, in the normal group, there is higher female prevalence in the intervention group. This slide presents the data of cognitive performance, frailty, and the functional status in each condition. About the MOCA scores, the baseline MOCA scores of the intervention group in cognitive dysfunction and the control group in mobility type frailty was lower. And some subdomain of MOCA also have significant difference for persons with PCDS and cognitive dysfunction. And there is also no obvious difference of first score, 30 scores in 4 groups, but lower hem grip strength of the intervention group in persons with PCDS and the slower gait speed of intervention group in cognitive dysfunctions were noted. This figure showed the mean change in cognitive function for each group from baseline to 12 months. You can find that multi-domain intervention improved the global cognitive performance of the PCDS group at 12 months. However, the effect appeared earlier in the group of cognitive dysfunction and lasted until 12 months. For the mobility type 30 group and the normal group, neither group have benefited from multi-domain intervention. In addition, regarding the subdomains of MoCA, we found that multi-domain intervention improved the naming and the concentration ability of PCDS group. While for cognitive dysfunction group, it has significant benefits in concentration and delayed recall function. This figure revealed the impact of multi-domain intervention on frailty and physical functions in each group, each conditions. And you will find that multi-domain interventions only improved frailty scores of participants with mobility type frailty. But the effect is only significant in the first half of the intervention period. In addition, only persons with PCDS in the intervention group showed significant improvement in hand grip strength. Next step, we further use the generalized linear mix model to analyze the significant changes in cognitive and physical outcomes at a different time point after adjusting the covariant under each condition. In the next few slides, I will show the effect of intervention on cognitive function of each group after generalized linear mixed model analysis. And asterisks and color squares show items with significant results. In this table, I want to focus on the PCDS 6 months after intervention. Here you can see that MoCA score did not improve through intervention at this time, but the concentration significantly improved. This table showed the results of intervention for persons with PCDS at 12 months. In addition to improving concentration, multi-domain intervention also has a significant impact on MoCA scores and the naming functions. For cognitive dysfunction without mobility type frailty, compared with the PCDS group, that no effect on MoCA score at 6 months. Multi-domain intervention improved MoCA score of persons with cognitive dysfunction significantly at 6 months. In addition, concentration at 6 months after the intervention was also improved. At 12 months, for the group of cognitive dysfunction without mobility type frailty, the effect on MoCA scores and the concentration function after multi-domain interventions lasted until 12 months. And multi-domain intervention also benefit on the delayed recall function at 12 months. For the group of mobility type frailty without cognitive dysfunction, multi-domain intervention had an early effect on visual spatial executive function at 6 months, but the effect did not persist until 12 months. And except for visual spatial executive function, we did not find any effect of multi-domain intervention on our cognitive domains at 6 months and 12 months. for the persons with mobility type variety. And in addition, multi-domain intervention also did not show any effect for normal group at the 6 months and 12 months too. And this table showed the intervention effects on variety score and physical function for each group at 6 and 12 months. Although multi-domain intervention significantly improved the variety score of participants with mobility type variety without cognitive dysfunction at 6 months, the effect only appeared in the first half of the intervention period at the 6 months only, and disappeared in the later period. Also, some physical domains were improved after multi-domain intervention. For example, hand grip strength increased among the persons with PCDS, and the gait speed improved in normal group at 12 months. There are still several limitations in our studies. First, this is a secondary analysis, and each analytic subgroup had a limited sample size that may have lessened the likelihood of detecting intervention effects. Second, information about participants' health-related lifestyle factors and comorbidities were separately reported, and we were unable to access medical records. Third, intervention used a general multi-domain strategy rather than individual domain-specific protocols, which precludes interpretation of the effects of individual interventions on different outcomes. In conclusion, PCDS is a good candidate with the potential to reverse cognitive and physical dysfunction after multi-domain intervention. Compared with original analysis for all subjects in the SIS study, who only had borderline benefit from the multi-domain intervention. You can see the result in the left figure. And in the middle figure is for the PCDS, and in the right figure is for the cognitive dysfunction in this secondary analysis. You can find that persons with PCDS and the cognitive dysfunction had a better benefit on cognitive function after multi-domain interventions compared with the original analysis. The reason for the insignificant effect for all participants in original analysis may be that the original analytic case did not exclude the people with low cognitive function. So maybe more intensive interventions may be needed to have the intervention effect for these groups. And the group studies, the study groups in our secondary analysis is similar to the subject recruited in finger studies. They included a person with mild cognitive dysfunction, MMSE between the 21 to 26, and we recruited participants with MOCA scored higher than and equal to 18. And we present the similar intervention effect on cognitive function as a result of finger study. And due to the borderline significant effect of original multi-domain intervention in all participants of the SIS study, in a secondary step of this SIS study, SIS redesigned and enhanced multi-domain intervention programs to empower and motivate individual participants. After following up feedback of original participants. In the empowerment study, we simplified the standard protocol to produce new training material and also create some new strategies to empower them and make sure the compliance with the intervention. For example, we provide a sheet and and pedometer to recall their daily number of steps, and encourage them to increase the number of steps to take 10,000 steps per day. And we also give homework of cognitive training and give them feedback after classes. So in the right figure, you can see that after we design the intervention program to empower and motivate the participants, compared with the result of original design, the benefit of multi-domain intervention on global cognitive function in the empowerment study significantly increased. In addition, early benefit on visual spatial executive function of older adults with mobility type 30 were noted, even if no cognitive dysfunction was noted. And multi-domain intervention only had a benefit effect on 30 scored in older adults with mobility type 30 only in the first half of the intervention period. And why the intervention effect cannot be sustained to the 12 months? This may be related to the degrees of the improvement of 30 status and the intensity of our multi-domain intervention. Evidence also shows that the executive dysfunction instead of memory impairment is highly related to referral or early failure status. In the secondary half of the intervention period, the intensity of our CIS study was reduced. So this may explain why the frailty and the visual executive function did not improve for 8 to 12 months. And based on the sum of the above discussion, it's best to improve prevention effect if we focus on the persons at risk and study the intervention to reduce the risk as early as possible. And this kind of multi-domain interventions has been applied to communities throughout Taiwan. In the near future, it's hoped that there will be more and more evidence to support the effect of multi-domain intervention. So thank you for your listening, and I hope you enjoy my talk today. And thanks.
Thank you, Dr. Liang. And so we'll move on the third speaker of this session, and then we'll have a discussion at the end. The third speaker is Dr. Li-Ling Pan, who is from Taipei Veteran General Hospital and National Yangming Jiaotong University, who is also the Division Chief of Geriatric Medicine and the Associate Professor in the Department of Geriatric Medicine, National Yangming Jiaotong University. And the topic she's going to give is a pretty challenging and difficult one. That is how to build up the digital twin for the PCDS. That is very important topic. So let's welcome Dr. Peng.
Thank you. Ladies and gentlemen, I'm Li-Ling Pan. It's my honor to be here to talk about the topic, developing the digital twin of PCDS, application of AI. And actually, digital twin is a new vocabulary word for the biomedical researchers, and it is ongoing progress in many specialties. In our project, we are going to build up a digital twin for PCDS, and we try to make it and have done the preliminary analysis to prove the concept and realize it might be feasible. So today I will briefly introduce what it is and show the data with you. Okay. Have you ever seen the movies Apollo 13? That is a true story, and it might be a good example of digital twin. In 50 years ago, around 200,000 miles away from Earth, a mission of moon landing was suddenly aborted after an oxygen tank explosion. Something was seriously wrong, and all the astronauts were stuck in the spacecraft and unable to see the full extent of the terrible damage. Without oxygen, the life support system and the service module cannot operate. So besides, any wrong decisions may cause further terminal damage to the fragile spacecraft and threaten the crew's life. So could you imagine, in these dangerous circumstances, how the astronaut diagnosis and solve the problem far from the Earth and outside the human intervention? Actually, behind the scenario in the outer space, there were 15 simulators in NASA, which were used to train the astronauts and the mission controllers in every aspect of the mission, including multiple failure scenarios. So the simulator helped them to find out how to maneuver and how to navigate the badly damaged spacecraft, and find out the innovative way to conserve the oxygen, water, and power while keeping the astronaut and the spacecraft system alive. Okay. So finally, they restarted the command module, which was never designed to be switched off in space, and then all the astronauts come back to Earth safely. So the simulators were perhaps the first real example of digital twin. It could save the people's life based on a bunch of computers, a lot of formula, and many skilled technicians. So regarding to the evaluation of the digital twin, the digital twin is a virtual representation that matches the physical attribute of a real-world factory, plant, or other products in real time by using the sensors, cameras, and other data collection techniques. So in the beginning, there is no any idea about the digital version. We can just make physical version for anything, like an airplane. But gradually, people start to think, maybe we can have a digital version to do all the simulation and then feedback to the physical version. That is the second stage. But in last stage, the digital version and the physical version are not connected. Then move on to third stage, like Apollo 13. The physical version collect the data in real time and feedback to the digital version. Then the digital version to do the simulation quickly and feedback to the physical version and provide the solution. So right now, we are hoping to have the digital version together with physical version so that we can do things at one time. In real world, the first digital version was in NASA. They used the digital twin to build up an airplane. If we look at the left side, the true airplane has a lot of sensors to detect signal from the inside and outside and how pilot responses to any situation. Those data collected to the digital twin. In digital version, it started to a lot of simulation of the environment and see how to change the design and improve the performance. If we look at healthcare systems, it is possible to apply the technology on healthcare. Maybe the signals can detect from the environment, clinical biomarkers, and intervention response, and collect the data to the digital twin. The digital version can estimate the health risk and simulate the biological response and the intervention effect. That is the concept of the digital twin on healthcare. This is the envision of clinical workflow. The population data collected from the preceding patients and the study cohort to create and validate the statistical and mechanistic model, and as well as to create a population-based digital twin. The novel patient data also were analyzed in this model and to form the patient-specific digital twin. The comparison and the interaction of the digital twins give the valuable insights that include in the phenotyping, risk assessment, and the prediction of disease development. So the digital twin develop in line with the patient condition adjusting, and then as well as to improve in accordance with the follow-up data. So the resulting outcome was supplemented to shape the population data and then refine the follow-up data. There are several applications on healthcare system, and this is one example of real product of the digital twin on healthcare. During COVID-19 pandemic, people do a lot of image, such as chest X-ray and the chest CT, as well as hemodynamics data and biomarkers to build up a digital twin for COVID-19. Using the platform, people can simulate the blood and the oxygen flow of the trachea and the lung. Through the AI training and the simulation data, the digital twin helps the physician to determine when is the best timing to do the endotracheal intubation. So that is an example. We need not to do a lot of assessment for one single patient. We just need to collect the necessary data to predict the clinical outcome. So it is possible to apply this idea and the concept into health aging. Health aging is a positive term that emphasizes the functional ability and the intrinsic capacity to prevent dementia and disability in late life. However, if a patient has the early decline on physical or the cognitive function, that should be an unhealthy aging phenotype. We published papers with NCGG colleagues and described PCDS was a phenotype of unhealthy aging. So if we would like to make a digital twin on PCDS, it is more difficult than other digital twins right now because dementia or disability are related to a lot of different factors, not just an organ like a lung or a heart. So it's more like a systematic biology. So we need to pick up all the factors together. So everything is about simulation based on your available data. In our project, we collect data that including the clinical data, questionnaire, omics, and image data from the three big cohorts. One is from Japan, NCGG, that is NILS LSA, and the other two is from Taiwan. One is from the National Health Research Institute, that is health cohort. And the other one is our cohort, that is ELAS cohort, belonged in National Yangming Jiaotong University. We are hoping to build up a digital twin for the PCDS. Although the the data variable are not consistent in the 3 cohorts. So we would like to do some data imputation to build up the digital form. Before integrated and analyzed the big 3 data, we did the pilot studies to prove our concept. In our last cohort, some data are complete data. We use the data as developmental data to build up the AI model. And then some of the data are incomplete data. That means some data are missing. So we use this data to validate the AI model after data imputation by KNN. Then we integrate the data 1 and data 2 to build up to predict frailty and sarcopenia. The 2 conditions have established operational definition. So in our project, we collect data all from the ELAS cohort, and there are 4 different data variables. One is the clinical data. That includes a lot of questionnaires and basic demographics. And the second and the third part of the data are the data we have done previously for the metabolomics and the proteinomics. The first data are MRI. In this analysis, the data of clinical data, metabolomics, and the proteinomics were used for analysis. Then we did the feature selection. We removed those features missing rate over 70% and retained 1,036 features that include 102 clinical data, 502 metabolites, and 432 protein. Then we move on to deal with the data 1. We remove all the subjects with data loss and kept 465 subjects, those who with the complete data. And the complete data can continue to do the feature engineering by AI model to pick up the necessary features for the model establishing. So in this example, for predict frailty, we can find that when the feature number is around 20, the model is stable. But the feature number increased to 40, the model is better. After we deal with the complete data, then we move to deal with the incomplete data, that is data 2. We used KNN for data imputation. Then we used this model to check the validation and the accuracy of model. But we are not sure the missing data can be replaced successfully by the data imputation by KNN. So we did some tests. If we use HbA1c as the target variable, we can find the missing rate is very low, only 0.1%. And we use KNN to imputation and use the map to validate the accuracy. And we can find the result is pretty good after validation by 10% of the subject. If we look at the difference between the real measurement and the estimation, we can find the difference is very small. And then we use RASM as the target variable. The missing rate is about 3.3%, and the result is quite good. The map is 6.1%. So that gives us more confidence to use KNN to do the data imputation. Then we do some examine to the data of metabolites and the protein. In the left side, we take one of the metabolites, and in the right side, we take one protein to validate. Actually, the result is not bad, especially the metabolite. We can find the missing rate is very high, but the accuracy of validation is pretty good. So it is possible to use KNN for do the data imputation and maybe have a good accuracy for validation. And then we were sure to how we apply the model to predict frailty. In the data 1, that is complete data, we select top 20 features to build the model. The 20 features include 4 clinical data, 1 metabolite, and 15 proteins to build a model. And we validate the 20% of the data 1, and we can find the the accuracy and the accuracy is pretty good. It's around 82% and near 90%. And we deal with the data 2, that is incomplete data. Some data has lost the features less than 13, and we can find the accuracy and AUC curve is around 80% and 87%. If we look at those features missing number over 13, we can find the AUC and the accuracy was dropped a little to the 75% and 81%. How about sarcopenia? It is possible to apply the model to the sarcopenia digital twin platform. We use a similar way to predict sarcopenia. We select top 20 features. This is the first try we use only 1 clinical features, that is age. And the others include 6 metabolite and 13 protein. And we can find why we select the top 20 features, because top 20 features has the good accuracy and AUC. So then we use the left subject with the complete data. We use the data of 465 subjects and find the accuracy and error under curve is around 77% and 82%. If we use KNN to impute the data, we can find after incubation of 103 subjects, the accuracy and error under curve drop a little to 70% and 75%. So the prediction of sarcopenia digital twin is not good as the frailty. So that is the work we need to do more to deal with this situation. So in conclusion, overall, the digital twin concept is likely in biomedical research and maybe feasible in PCDS. Based on our available data set, KNN is a feasible solution to do data imputation. Before the PCDS digital twin, I think further efforts are needed that include the concrete diagnosis criteria of PCDS and extensive laboratory work for a variable of interest. Okay, thank you for your listening.
感谢3位讲者为我们带来精彩的演讲。现在为综合讨论时间，有请讲者来到台前，欢迎各位学员踊跃提问发言。Thanks for all the professors given us the wonderful speeches. Now it's general discussion. Sincerely invited all speakers come to the stage.
Thank you. There are many questions. That's good. We have very active audience. So first two question is for Dr. Zhuang. That in your study, despite the statistical significance, the difference of few biomarkers in the two groups has minimal clinical meaning, such as HbA1c 6.1 versus 6.4. So what's the clinical application in your research?
I think that maybe if the diabetes patient, their glucose control is poor, maybe they have more high risk to develop the PCDS symptoms. So if the elderly with diabetic elderly has well glucose control, they may low risk to develop the PCDS. Okay.
Thank you. So I will finish all those questions from the audience first, and then we'll see if there's any further comments. And second is for Dr. Liang, that in your study, because the CIS inclusion criteria include people with subjective cognitive decline and or impairment of one IADL. So although that in your study, the objective measurement for the neuropsychological test is improved, did the participants subjectively feel improved in their cognition? Do you have data to share?
Okay. So your question is, does the participants feel their cognitive function improve subjective?
Yes.
Yes. So we don't have the data to show the result, but because we measure the objective, the cognitive function. So sorry, I can't answer these questions. Yes. Yeah, but I have no data to show that. Yeah.
Okay, it's such a quick answer. So, okay, the third question is for Dr. Peng. Thank you for sharing this new and exciting ideas. What do you advise that you're going to give for the young physicians in view of this change of using the digital twin?
Thank for your questions. And in my opinion, I think the young physician is very lucky because they have a lot of tools to predict the outcome and not just under the clinical experience. But I think they are very not lucky because they need to learn a lot of things to understand why the AI give your answer and the answer and the feedback you need to combine with your traditional data and is in a process of clinical decision making. So I think for the young physicians, I think they need to learn more and more humble.
Thank you. I think the future of young physician will be very challenging. Yeah, that is my feeling too. Okay, another question for Dr. Liang. That overall, the intervention effect of your study is not very big. But of course, in the long, that effect can accumulate year by year if you can continue the intervention. But do you think that's because in your study, you enroll participants based on subjective cognitive complaints? Would the effect be bigger if we use the objective measurement for the neuropsychological performance?
Your question is if
should we use the objectively measured cognitive neuropsychological test to identify people at risk compared of using subjective cognitive complaints?
Oh, yes, thank you for your questions. Yes, from our study, we can find that we try to use the objective cognitive measure to divide people with the PCDS or cognitive dysfunction or mobility type frailty without cognitive dysfunction. So the results showed the benefit of the multi-domain intervention on cognitive function, based on the objective cognitive measure, not the subjective cognitive measure in this study. So I think, yes, it's also a problem that how we can apply a simple or easily cognitive assessment in the community to screen persons with PCDS in community, easy to screen this kind of the people at risk is also a kind of problem we need to explore in the future. Yeah.
Thank you. That in community work, we have different challenges compared to the hospital. In hospital, sometimes we want to pick up the right person for intervention, for treatment. So we would do a lot of assessment to identify those who are at the highest risk and who can deserve the best effect for intervention. But however, in the community, if you're focused on the community living older people, that means that if you're using the same approach like a hospital, that means you're going to spend a lot of money and effort and manpower in doing the assessment. So I think experiences from Japan in doing the disability prevention services, they found that we spend too much effort and resources in doing the assessment. But if you further categorize people in the community with high risk, medium risk, low risk, and you want to provide different approaches or intervention program, that would be too complicated in the community. So although the criteria from CIS looks that the overall the benefit, the effect size is not big, but if you continue to do it year by year, and the effect and the benefit can be very impactful. So that's different approach from clinical setting, hospital, versus from community setting. So here I finished the questions raised on my tablet. So is there any question from the audience or from our Japanese colleagues in the NCGG?
May I ask?
Sure, yeah. Please.
I have a question. To ask for one for Dr. Liang, and the other one is for Dr. Peng. For Dr. Liang, I think your intervention result is not very effective on the mobility type frailty, and your recommendation is that we have to strengthen our intervention program. However, I just wonder that because the inclusion criteria is for the walking speed is less than 1 meter per second. Do you think that if we make it more strict, if we just include the gait speed for those who lower than 0.8 meter per second, do you think the effectiveness will be greater and become significant? And the other one is for Dr. Peng. For the last slide that you make a prediction model to predict sarcopenia, I saw that you use 20 features to predict, including age and metabolomics and some protein. However, because we know that the sarcopenia actually is some criteria to define the sarcopenia is the muscle mass and also some physical function. I wonder if we include, for example, the hand strength or the walking speed into your feature, do you think we will make the prediction power more increase? Thank you.
Dr. Liang, are you here?
Yes, I'm here.
Yeah.
Okay, I try to answer the questions. Yeah. So because in the beginning, the state studies tried to screen community during older adults with maybe at risk of the future dementia or disability. But yes, the criteria of the inclusion criteria in the state study is not so. The people in the state study is not so low. Not had those physical or cognitive performance, but in the study, the result, we divide the participants into the 4 groups, and yes, we only find the multi-domain intervention can improve the frailty score in the mobility type frailty. Yeah, and the average score of the in this group, and their get speed value in this group are around 0.9. Yeah, so if we can enroll the people with slower get speed, maybe less than 0.8, maybe the intervention effect maybe more than the current participant. Yes, I'm agreed with this. Yeah, so
Okay.
yeah.
Okay. Thank you, Dr. Liang. That because in the cohort from Yilan and in Taipei, for the 6-meter usual gait speed, the lowest quintile is more than 1.0 meter per second, eventually up to 1.1, which is similar to Japanese cohort. So using 1.0 meter per second eventually is the lowest quintile for the general population. Well, yeah, of course, if we lower down to theoretically, if we use 0.8, it does not increase the case, it decreases the case, because at 1.0 we can have more case. So, yeah, but to focus on people who are at higher risk should gain the better efficacy. That is for sure. But it's a balance between community approach to get the effect bigger. So, Dr. Xu, you have a second question for Dr. Peng?
Okay, first, thanks for Professor Xu's questions. And in our analysis, the feature we select is by AI. And according to a slide, around 1,000 features that include clinical data, metabolomics, and proteinomics enrolled to analysis. So that is our operation, that is AI selected. So that is the best model to predict sarcopenia, and which has the best accuracy and the area under the curve. So I think physical performance or the hand grip are the factors we know, but I think there are something we don't know. So we need to AI to help us to select something we don't understand and which are not tested before. So I think this the model help us to realize more we cannot understand. So that is example. Thank you.
Okay, thank you. Any other question? If no, I guess you're all hungry, and we're pretty much about time, but before I close this session, I would like to ask one question for you. That, compared to the data from Japan, the biomarker basically has no difference. But that is also slightly unusual that if you pick up the phenotype with two extremes, there should be some difference. So maybe their participants are very homogeneous in many ways, and they're too healthy. But what about in your cohort? Because can you more in detail explain why the walking speed seems very different in your cohort compared to Japan? And most of the cardiometabolic risk you identified in this cohort would it be linked to the cardiovascular outcomes in your follow-up?
I think in our cohort, because the measure of the walking speed with different measure, we use the all participants they sit and they stand up to walk 3 or 4 meters. And this measure may be different with other studies. Studies may use 6 meter walking, and some study they measure the less 4 meters. So their walking speed is higher than our studies. And another, we analyzed the PCDS spectrum difference lower and higher, and we find that some cardiometabolic disorder trait is very different, and this phenomenon is different to Japanese population. Maybe I think that can explain because the glucose or hypertension or lipids, if the elderly with this disorder, they usually will be treatment. They will be treatment. So if we look at the value, no difference. Maybe they have well treatment. So maybe in Japanese population, the homogeneity, maybe the elderly has well treatment, and they have good doctor have follow the doctor's treatment guideline for. But in Taiwanese population, may not have well treatment because the patients not to follow the treatment guideline. Okay, thank you.
Thank you. In our previous epidemiological study using CBAS cohort, we found that PCDS predict all-cause mortality and cardiovascular mortality. So probably, yes, your observation is very important that the cardiometabolic risk is an important underlying risk factor for the PCDS and the outcomes. So I think that would be very important and interesting thing, and in clinical perspective, that also strengthen the needs for chronic disease management to incorporate with multi-domain intervention. That should be prescribed for patients with cardiometabolic disease, because they have their overall health risk is much more than they expect, not just on cardiovascular disease, but also on disability and dementia. So that would be a very interesting and important finding. So thank you very much. I would like to close this session, and I hope you enjoy the session, and we will come back later. And there will be some housekeeping information. Thank you.
感谢各位踊跃的提问及发言。各位来宾，现在是中午休息时间，感谢各位来宾的参与。请各位来宾持餐券兑换午餐便当，用餐地点在103教室。为避免影响学员权益，再次提醒所有学员于离开前，记得完成线上的签退表单。感谢大家的配合。下一场演讲将于下午1点30分开始。Thank you all for your participation and comments. The next session will start at 13:30. Thanks for your cooperation.
各位来宾，大家午安。身智衰退症国际研讨会即将开始，请各位来宾尽速就座，并请您的行动电话关机或转为震动模式，以免影响场内会议的进行。提醒各位学员，本次课程已申请公务人员、系医师、老年医学、家庭医学、护理师、专科护理师、药师及营养师学分。如欲取得相关学分，请务必完成线上签到、签退表单以及会后的满意度调查表。谢谢您的合作。Good afternoon, ladies and gentlemen. We are delighted to have all your guests here attending International Symposium for Physio-Cognitive Decline Syndrome. The symposium is about to start. Please turn off or set your cell phone to vibration mode. Friendly reminder, don't forget to fill online sign-in sheet. Thanks for your cooperation.各位来宾，大家午安，欢迎莅临身智衰退症国际研讨会。Good afternoon, ladies and gentlemen. We are delighted to have all your guests here attending International Symposium for Physio-Cognitive Decline Syndrome. 有请台北荣民总医院高龄医学中心李明宪主任为我们主持。Let's welcome Dr. Ming Xian Lin, the Director of Center for Geriatrics and Gerontology of Taipei Veteran General Hospital, to host the following session.
Superintendent Chen and Professor C.O. Xu and everybody here and all the participants online, good afternoon and welcome back. Now we will move to the third section of today's symposium. The first speaker is Dr. Li Weiru. Dr. Li was a graduate from School of Medicine, the National Yangming University, and was also PhD of Institute of Public Health of National Yangming University since 5 years ago. Now he is the assistant professor and the chief of Division of Geriatric Medicine at the Yuanshan branch of Taipei Veterans General Hospital. He will share with us about the Tiger study. The one in Taiwan might be compatible with the worldwide famous finger study. So now let's welcome Dr. Li.
Thank you, Director Lin's kind introduction. Good afternoon, ladies and gentlemen, and the online participants. I'm Weiru Li from Taipei Veteran General Hospital, Yuanshan Branch, and National Yangming Jiaotong University. It's my great honor to have a talk here to share our data on PCDS by our Tiger study. A lot of studies shows the benefits of exercise, psychosocial, chronic condition management, nutrition, and preventive services on disability and dementia prevention. Putting all these elements together has become a mainstream for those dementia or disability prevention. A most famous trial is finger study. Finger study is the first large-scale randomized control trial to prove the benefit of multi-domain intervention on cognitive prevention. Because of the huge success from finger study, the Worldwide Finger Network has been organized to share data, knowledge, and experience to conduct randomized control trial to prevent disability or dementia. And we are one of the network. However, finger study has a very intense protocol. All participants must go to sports center or on-site to take some training 2 hours a day, 5 days per week. They result in 2 problems. It is not easy to implement in the real world because government needs more money, more budget to support this project. And the old adults are very busy. They are too busy to do all this protocol. So we designed a cluster randomized control trial. We use the less frequent intervention. The details was introduced by Dr. Liang in the last section. And in this phase study, we prove multi-domain intervention would benefit on community living old adults. It could reduce physical frailty, improve nutrition, depression, and enhance cognitive performance. However, in this study, we still not touch the core of healthcare system, the physician, the value care healthcare. So to solve this problem, we designed a new randomized control trial. We use the multi-domain intervention plus integrated primary care to examine the effectiveness of this intervention protocol. And more important, we look at the
the outcomes, we use the value-based matrix to measure the outcomes instead of a single disease, because we believe pursuing a system-wise efficacy is more important beyond single medical condition management or single function management. So we study Tiger trial. This is our trial. We select 6 research sites, include the primary physician, include the secondary or tertiary centers. And the inclusion criteria were participants older than 65 years old and having 3 or more chronic conditions, and they will be eligible in national health insurance. Those receive active chemotherapy for malignancy or life expectancy less than 1 year, or they are live in the long-term facility were excluded from the Tiger study. Totally, we screening around 600 participants and around 400 participants randomized allocated into intervention or usual care group, and we have pretty high completion rate, more than 18%, around 84%. And here is our study protocol. The aim of our study is to nurture our participant a healthy lifestyle instead of calling them on-site to do some exercise. So we consolidate their healthy life habit in the first month. So we ask them to go to our training site 4 times per month, and then we lessen our intervention frequency to twice per month, and then since the 3rd month, we only give them once per month to remind the participant how to maintain healthy lifestyle. And compared to the THIS study, we have multiple measurements, repeated measurement for our outcomes. We ask our participants go to our research center every 3 months. So we have 5 repeated measurements to see their quality of life, to see their cognitive function, to see their functional outcome, and also we check up their laboratory data. Here's how we train our participants. We have 2 hours classes. Each class contains 1 hour cognitive training. We adopt a group-based intervention, and we train our participants face-in-face, and we elect a group leader. We ask our group leader to encourage their member to attend the class, and also encourage them to complete the homework we assign. We train them, the content includes some commercial products such as Sudoku or some stake games for train their spatial skills. And we give them some cognitive training exercise at home, and we will check up their homework at each time they return into our research center. On the fitness and exercise program, we train their muscle strength, balance, and flexibility, and also we encourage them to do some homeworks at home. And we encourage them to complete aerobic exercise such as fast walking around 150 minutes per week. And we ask them to report their steps after that. On the nutrition education, our dietitian provides some protein-based nutrition suggestion based on our government's dietary reference index to enhance their protein intakes. Here is our outcome measure. We use ITRON value-based healthcare score system. The ITRON system measures 3 tiers from all health outcomes. The tiers 1 measure the direct medical outcome, such as frailty, and the second tiers measure the treatment or recovery process, such like polypharmacy for our participants. They think what is they participate in medical decision making. And the third tier belong to the long-term health outcomes, such as loneliness, physical function, slowness, pain, or depression moods. And also we compose a value-based score, range from 0 to 10. And the higher score indicate the higher value-based healthcare. And here is our outcomes. The intervention from Tiger study could improve the global cognitive performance and all individuals' cognitive performance. And when we look at the details of the matrix from iTrums, we could find the most important long-term health outcome, limited IDL, limited physical function, slowness, and pains were all significant improved from this intervention. And when we look at the quality of life, we could find the intervention from Tigers could significantly increase the physical component summary scores and also improve the mental MCS at the 12 months. Most important, on the physical role limitation, the improvement is very great. It's greater than 3 points. That means a huge improvement in this quality of life, and it may be contributed by the improvement by physical functions. And then this is PCDS proposed by Professor Chen. The details was introduced in this morning, and PCDS has become a novel target for healthy aging promotion. So in this part, we want to use our Tigers database to examine the multi-domain intervention plus integrated primary care on the effectiveness of for PCDS. So we use the PCDS definition from Professor Chen's proposal. We use the Tigers database. In total, around 398 participants were in the Tiger study, and we exclude a MOCA score less than 18 score as 58 participants, and in virtually we get 340 participants in this analysis. And in this analysis, we found around 28% participants had PCDS. And on this 1 year follow-up, more than 75% complete all these follow-up. Here is the baseline characteristics. We can see all of these baseline demographic data show statistical insignificance, so they are all similar except on robust group, the intervention group had lower male proportion. So in the following analysis, we will adjust for the original Tiger studies variable plus the sex. And we have two questions. First, we ask, did the participants with PCDS had worsened functional outcomes? And is there any difference between robust or PCDS group on their intervention effects? So we conduct a linear mixed model adjust for associative variables. We could find those with PCDS had worsened worsen global cognitive function and associated subdomains. And if we look at the difference between the difference of treatment effects between robust and between robust and PCDS group, we could find the treatment effect was similar. So we could get a quick conclusion. PCDS group did have poor cognitive performance, but their treatment effect was similar with robust group. So it's a quite happy message from these findings. So we see this global the overall MOCA score. We could find robust CIND and the PCDS group all have significant improvements on MOCA scores. And if we cut the MOCA score less than 26 as the cognitive impairment, we look at them as cognitive impairment, we could find the CIND, and the PCDS also have significant improvement, which result was similar with this study introduced by Dr. Liang in the morning. And we further look at the participants of PCDS. We could find the concentration, abstract thinking, language, and the orientation all had the treatment effect all were very significant. And then we move on the next outcome we want to look at, the value-based scores and the frailty phenotypes. We accumulate we account all the 5 phenotypes found in DAF-3s. And the similar question to answer. Participants of with PCDS had worsened value-based scores, and also they had higher frailty phenotypes. And in the difference of treatment effect between robust and PCDS group, they were similar, both for value-based and frailty phenotypes. And so we will look at the details improvement from the phenotype, the frailty phenotypes. We could find the SIND and the AMID all had significant improvement for frailty for a year's period, but PCDS and robust were not. And on the value-based goals, all these 4 subgroups did not have significant improvement on this. And eventually, we look at the final outcome. We want to look at the quality of life. We also answer the first 2 questions we want to answer. Do the PCDS participants had lower quality of life from physical components? The answer is yes. The quality of life from physical summary components and the physical functioning, physical role limitation, and the general health were worsened on PCDS, but not on body pain. On the difference of treatment effects for PCDS and a robust group, the treatment effects were similar between all of these physical domain from quality of life. And on the mental domain, we could find the PCDS group had worsened vitality, emotional role limitation than the robust group at a year's follow-up, but not on the total score, the total mental summary component, or social functioning, or mental health. On the difference of treatment effects from PCDS and robust, the treatment effects were similar between these two groups. So we look at the PCDS, and we could find on the physical component summary scores, the PCDS intervention would benefit on PCDS group at the 12 months, and also had improvement on the physical role limitations and the emotion role limitations on at the 12 months, but not for the overall mental component summary scores. So here is our conclusions. Compared to the robust group, PCDS group had worsened functional outcomes, especially particularly in cognitive performance and quality of life. Involving primary health care and multi-domain intervention could enhance clinical efficacy in cognitive performance with PCDS SIND or robust. Fertility status in participants with SIND or MIND, and the quality of life, especially physical component scores, role limitation, role of emotion limitation at 12 months. So we believe the TIGER study provides a pragmatic model to enhance cognitive performance in the real life, especially for the PCDS. Thank you for your attention.
Thanks, Dr. Lee, for your wonderful speech. We will discuss later before the end of this section. Thank you. The second speaker is Dr. Zheng Songhua. Dr. Zheng was graduated from the School of Medicine at Kaohsiung Medical University. He is also studying in a program of molecular medicine at the International Yangming Jiao Tong University now. He is also the attending physician at the Center of Geriatrics and Gerontology at Taipei Veterans General Hospital. So let's welcome Dr. Zheng.
Thank you for Dr. Lin. Good afternoon, ladies and gentlemen, and online audience. It's my pleasure to share my study about how to screen PCDS in the community. And from today's other sections, we know the importance of PCDS and possible multi-domain intervention have a reversibility for PCDS, but how to screen PCDS in the community or primary care settings maybe have some problems. So maybe today's my sessions is maybe to introduce to the audience maybe how to develop or maybe possible to screen the PCDS. Okay. And it's a brief outline for today my presentations. Okay. So if we want to develop a tool, so maybe we need to review the definition. And we know the revolution of the definition of PCDS. The past definition may have some limitation, and so we have a new define. But if we want to have a tool, maybe we need to review the past tools and past definition. Then maybe we find some point view. Maybe we can to include in our screen tools. So the earlier definition is proposed by the IAGG and is use the cognitive domains use the CDR. So we know if we use the CDR to evaluate the cognition function, maybe it needs some more complicated. You need more time and more skillful investigators to do this kind of work. So maybe have some limited to diagnosis this kind of syndrome. Then, because the previous definition, maybe some revised definition was proposed. So some to propose maybe is focus on the reversibility of the chronic frailty. And it used the pre-MCI stage to define the cognition. But the pre-MCI defined by the previous definition, maybe you need the subjective cognitive decline, and you use the possible biomarker, for example, beta amyloid accumulation or other neurodegenerative or neuroinjury evidence. I think this biomarker maybe is very important, but it has some limitation in clinical practice. Maybe it's hard to check this kind of biomarker in our daily practice. And for other is potentially reversible, but potential maybe it's like the IRGG definition. Maybe the reversibility or the prevalence maybe is relatively low, so maybe it's hard to do the intervention programs. And maybe the most likely PCDS is a motoric cognitive syndrome. It uses the mobility dysfunction. It choose the slowness, and you use the subjective cognitive complaint, is SCD, to record the motoric cognitive syndrome. So maybe it's most likely the PCDS, but it's no any previous developed screen tool. So maybe now have some evidence. Maybe we can have for our reference. So now we have a new definition for PCDS, and so the domain of the PCDS is focused on the reversibility and maybe the prevalence rate in the community. Then we can have an intervention program. And the definition for physical domain is a slowness or weakness, and cognitive is for 1.5 standard deviation to for reference group. So this is our PCDS definition. So we use our aging cohort and to first to see how the prevalence of our definition. Based on the previous definition, maybe in the community setting, maybe around 1% to 2% in the community, maybe higher in the clinical setting. But if we exclude the disability, means it is have dementia or maybe some dependence in ADL, maybe the prevalence is relatively lower. And in our aging cohort, one is in E-line and aging cohort, and one is Taipei aging cohort. The prevalence rate in E-line is around 20%, and in Taipei City and New Taipei City, maybe 84%. And if you include these two cohorts together, it's about 15% in the prevalence. And we need to compare these two cohorts in the baseline characteristics. Maybe the baseline characteristic is similar, but maybe in E-line, the education levels is lower. So we have these two cohorts for our to develop a screen tool for PCDS. Okay. So today is important to how to screen. So refer to the PCDS, the physical domain. I think maybe it's easier compared to the cognitive domain, because the slowness we can to check the walking speed, and if we consider the weakness, we can use the device to check the hand grip stress. So I think it's easier to diagnose the physical domain of PCDS. But how about the cognitive domain? I think in the diagnosis, the definition of the cognitive impairment, some study use the subdomain cognitive test, and some use monthly cognitive assessment, and some maybe use the MSE. But I think this kind of cognitive test is time-consuming and maybe needs skill for investigator to do this. So I think if used in the community settings, maybe it's hard to give any primary settings to this kind of assessment. So maybe in the screen tools is how about to improve, just to improve detection rate of the cognitive impairment, or when to develop a new tool to screen for PCDS. Maybe it's our work in this study, maybe they try to solve. Okay. So first, although the PCDS, the biomarker or pathophysiology is more and more clear, but we cannot, in clinical, not have either biomarker to diagnose this kind of syndrome. So when review in start of the possible PCDS, so maybe have some factor maybe related inflammatory or immune factors, or maybe some laboratory factors, and other maybe some protein or some probiotics maybe can relate it, but not easy to get this kind of information. And I think the more easier one is the clinical measurement. I think if we want to use this tool in a community, the easier clinical measurement maybe is the easier one to develop this kind of tool. Okay. So in our predictors, we choose the simple clinical measurement, so including the personal and medical history and some questionnaire and some measurement, or like a calf circumference or a waist circumference. So the goal is to developing a convenient screen tool. And maybe we can identify the high-risk group in the community. Okay. We can see the previous study about a tool about how to screen the PCDS. And maybe it's very least, but we can find one is a Korean study. Use the calf circumference to screen the PCDS. Because the previous definition is called cognitive clarity, but I think the meaning is the same. So it is to try to use the calf circumference to screen the PCDS. And the result just show this meaning for the older men, because we can see the odds ratio is have a meaningful statistical significance in older men. So in that study, maybe you say the calf circumference is maybe can screen the PCDS in older male, so it's meaningful. So we use the same kind of tool, like we use the calf circumference to screen the PCDS in our cohort. So we put in the ELAS and last study, the two populations together. So let's see how about if you use the calf circumference to screen PCDS. And the result may be contrast to the Korean study. We see maybe is the older woman maybe have a statistic length. So in our study population, the calf circumference maybe can screen the older woman for PCDS. So maybe these two of study maybe have a conflict of the conclusion. So maybe I think just use the calf circumference to screen PCDS maybe is not enough. Maybe it is need another tool to screen. Okay, so we decide a new study, and our study population is used and the two cohort ELAS and LAST. Okay, and in the ELAS maybe we have near 2,000 adults over 50 years old, and in the new Taipei cohort we have near 1,000 adults. So we include the adults age below 65, and we include the disability. And our criteria is to define the disability of physical means it have any deficit in ADL or IADL score. And the cognition disabilities means if you use the MONCA test, it is below 26, and if you use the MSE, is to below 24. And all of these two tests when correct by the education year. It means if the MONCA test, if you have an education year below 12, we will add 1 point for that individuals. And if in MSE, if we below 6 years, when we get to get extra points for the individuals. And to define the PCDS, when maybe in last study, we define the cognition impairment means 1.5 deviation from normal individuals. And the mobility dysfunction, maybe you use a term dynapenia. It means the low weakness and slowness. And the cut point maybe previous LWGS criteria. Maybe you have a new one, but I think if you use the new one, the prevalence will be higher than in this study. So when you see the baseline characteristics of these two cohorts. Okay. So in the PCDS group and non-PCDS group, maybe you have a difference in age and sex, and also have in the clinical measurement, you have a difference in waist circumference and cuff circumference. And also we have mentioned is how different in education years. And also have some different in the personal history, like the alcohol consumption and maybe have the history of diabetes. And use some like the CS criteria like weight loss, exhaustion, maybe have the differently, these two groups is exhaustion, maybe have some difference. And also have the difference in subjective cognitive complaint and also the depression symptom is have a statistic difference in these two groups. And also is known interesting it have a different in hand grip stress. Okay, so we have these indicator have a difference in these two group, PCDS and non-PCDS group. So we put these possible factors to build up a regression model. And also, we see the result. Okay. We mentioned is have maybe cuff circumference maybe is important for old woman with PCDS. But how about the circumference? Because we can see have the waist circumference have a difference in these two groups. So we use the waist circumference to screen PCDS, maybe it's also meaningful for the woman, because in the aged woman, maybe the wider the waist circumference maybe have more risk for PCDS, but it's not have the same situation in older men. So if we put two together, we use calf circumference 8, waist circumference, maybe some interesting finding we can see. Overall, no matter woman or man, if we have a lower calf circumference and higher waist circumference, maybe have a high risk for have a PCDS. But if only refer to the woman. If a woman with a high waist phrase and low circumference, maybe it have more risk than the man. So maybe a higher waist circumference maybe is a protective factor for the man with PCDS. Okay. So, but in our regression model, just use the weight second phrase and curve second phrase may not enough. Maybe use the age under curve, or the sensitivity or specificity is not enough. So finally, after to compare different regression model, we build up a final model is have the based sensitivity and specificity. So we have some, maybe we have 6 predictors. One is the age. Age over 75, maybe have one in our screen 2 is one item. And if the individual is female 6, means another item. And if the weight second phrase is referred to, is a reference to our cutoff for in Taiwan population. Maybe the weight second phrase in woman is over 19 cm, and in female is over 18 cm. And the curve second phrase is if in male is below 33 cm, and female is below 32 cm. And also the subjective memory decline, I think, is important for screen the PCDS. Maybe if we want to diagnose it, we want to use the subdomain cognitive test. But if for screening, I think the subjective memory decline is meaningful for screening. And the history of DM is also in our models is maybe can contribution to one item. And we adjust the beta values to the score. So we build up a 14 score to use for screen the PCDS. Okay. And because we have 2 cohorts to compare, so we use the Elan aging study as a developing cohort, and the Taipei aging cohort for validation. So we can see if the sensitivity and the result of sensitivity and specificity. So if you use the cutoff at 5 points, when our sensitivity can reach 30% and specificity can reach 16%. And if maybe the each score is convenient, and maybe it can adjust his cutoff score, because if we need more specific, maybe we can use the 0.8, because it specific can reach the 93%. But to have a balance in sensitivity and specificity, I think our recommended cutoff is 0.5. So a conclusion of our study is maybe for the screen for PTDS, maybe this our developer tool is very convenient to the primary setting to use, because most of these items is including in our regular health exam, and despite the memory deficit. So if we add these questions is our regular health exam, maybe we also can it's easier to aid in our current daily practice, and easy to define the high-risk group to develop for PCDS. Okay. Thank you much, and it's today my about sharing about my tool to screen the PCDS, and welcome any comments and questions in the discussion session. Thank you.
Thanks, Dr. Zhen's impressive speech. This session is ongoing very fast, so maybe we need a lot of questions to discuss later. So our third speaker is Dr. Zhou Mingyue. He will introduce the impact of late onset diabetes on PCDS. Dr. Zhou was graduated from School of Medicine, National Yangming University, and he is also a PhD of Institute of Public Health at National Yangming University last year. Currently, he is the Division Director of Geriatric Integrated Care at Kaohsiung Veterans General Hospital. So let's welcome Dr. Zhou.
Thanks for Chairman's kind introduction. I'm Mingyue Zhou from Kaohsiung, and today it's my great honor to share the topic about the clinical outcome of all the onset diabetes and the implications to PCDS. As we all know that the prevalence of the diabetes increase as aging, and the prevalence of the diabetes will increase significantly in the future because of the change of the lifestyle and the diet. So in the future, we will face more and more older people with diabetes. And in the current data in Taiwan also show that in the past years, the prevalence of diabetes increased significantly, especially in the older age people, even in the male and the female. And about the epidemiology of diabetes in Taiwan, the prevalence increase and the trend is similar to the worldwide trend. And from the 2000 to 2009, the population of diabetes increased for 80%, and the prevalence rate increased for 55%, and the incidence rate increased for 25%. And the people with diabetes account for the total population for 10% in 2013, and the number will increase to 13% of total population in 2035. And of late, more than half are older people aged 65 years old. And we all know, several studies reported that diabetes are related to the function limitation and disability, according to some cross-sectional study and some longitudinal study. So they conclude that the diabetes is associated with a higher risk of developing functional limitation and disability with ADL and the IADL impairment. And the decrease of the muscle strength and the muscle quality are also the potential mediators of the association between diabetes and the functional decline and the disability. And there were some pathways from the diabetes to disability, and the pathway are maybe multiple pathways. And so the diabetes, they will cause comorbidities and will cause the impairment and become functional limitation and disability. Also, the diabetes will cause the impairment and the functional limitation and the disability. Also, there were some reports showing that the diabetes are related to dementia. For the older people with diabetes, they will increase the 60% of the risk to develop the dementia, even for the vascular dementia and the non-vascular dementia. And the attributable risk of the diabetes for dementia is about 6 to 7%. That means 1 in 15 cases of the dementia is attributable to diabetes. And there are some pathophysiology of cognitive dysfunction from the diabetes. For example, maybe they come from the hyperglycemia, the hypoglycemia, the insulin resistance, and the vascular disease, and the inflammation and the oxidative stress that will cause the cognitive dysfunction and the cerebral damage. So if the older people, they have the diabetes, they maybe have the underlying mechanisms for atherosclerosis. They will have the microvascular disease, the glucose toxicity, and the insulin resistance to cause the increase of the secretion of the decreased breakdown of amyloid, and maybe it will cause the dementia. And some evidence also show that for the older people with diabetes, if they have the hypoglycemia, they will also increase the risk for dementia. and even one time for hypoglycemia or more times of hypoglycemia. The higher number of hypoglycemia, they have a higher risk for the dementia. So for older people, if they have the hypoglycemia, they have some risk factor to develop hypoglycemia. For example, they have the tight glycemic control, or they have the higher age, undernutrition, and so on. And if the older people, they have the hypoglycemia, they will increase the risk for cognitive impairment, increase the risk for hospitalization, and the fall, and so on. And they will also develop obesity and develop the adverse outcome for disability, dependence, and the mortality. But for the diabetes in the older people, some older people, they have the diabetes in the late age. They maybe have the diabetes at the age 65 years old. And some other people with diabetes, they may have the diabetes for a long time. They were diagnosed with diabetes from the midlife. So maybe there are some different characteristics for these two groups. And the previous study showed that to compare with the late onset diabetes, for older people, if they have the diabetes from the midlife age, they will have high risk for microvascular complications. And the previous study also showed the different characteristics between late onset and non-diabetes older people. To compare with the non-diabetes people, for the older people with late onset diabetes, they will have higher mortality, higher microvascular complication, and so on. But one study coming from Scotland, they follow up the older people with diabetes for 10 years. And to compare with those without diabetes, they find that in the female also they increase the mortality for 10 years mortality. But for the male, they found that there is no increase for the mortality in 10 years follow-up. That means they conclude that for the older people, the male people with late onset diabetes, there is no higher mortality compared with those without diabetes. But how about the condition, the condition in Taiwan? So our study group, we utilized the longitudinal cohort of diabetes patients database from 2001 to 2011 to explore whether the late onset diabetes will cause the mortality or not in the male and the female. So we choose some participants from the database, and we pick up some control group from the longitudinal health insurance database by propensity score matching, and we find that for the male with late onset diabetes, they will increase the all-cause mortality compared with those without diabetes. So in male and the female, our study in Taiwan, we find that they will increase the all-cause mortality compared with those without diabetes. So that's the different finding from the report from the Scotland. And for the CV mortality, we also found that in male and the female in Taiwan, if they have the late onset diabetes, they also increase the risk for CV mortality and the CV complication. And another interesting finding is that if they have the hypoglycemia, they will increase the mortality in male and the female. And the characteristic of older onset diabetes among older people have been well reported. And in our current study, we explore the clinical characteristic of older people developing diabetes in different age. And we also explore the difference of longitudinal outcome among them in different age onset diabetes. So we conduct a retrospective population-based longitudinal study, and we utilized the database from the Taiwan National Health Insurance research database from 2000 to 2013. And we defined the newly diagnosed diabetes in 2003, and they should have at least one hospitalization due to the ICD for diabetes, or at least 2 outpatient visits for diabetes, or at least 1 outpatient visit, and the prescription for diabetes medications. And we exclude the diabetes record in anyone having the diabetes record in 2000 to 2002 for the definition of newly diagnosis in 2003. So we exclude those with diagnosis with diabetes in 2000, 2003, and we divide the participants into two groups according to the age they onset, from age 40 to 64, 65 to 74, and 75 to 84, and age more than 85. And we use the definition of the diabetes-related complication for macrovascular complication and the microvascular complication according to this ICD-10. And we define the major adverse cardiovascular event, the MACE, according to the CV mortality, myocardial infarction, and the stroke. We use the diabetes complication severity index as the surrogate of the severity of the diabetes control. But it's well validated for the DCSI for the claim data to use it as the severity of the diabetes. But they should use the report from the urine protein and the creatinine. So Professor Shaw, they validate the adapted DCSI. They can use the claim data only to define the severity of the diabetes control. So in our study, we use the ADCSI for the surrogate of the diabetes control. So for this study design, we include those older people. Those people, they were diagnosed with diabetes in 2003, and we classify them into 4 groups according to the age. And we also follow up their complication and the mortality for 10 years to 2013 for the cumulative incidence of the diabetes-related complication and so on. And we also we also measure the outcome measurement according to the all-cause mortality, CV mortality, and the MACE and the hypoglycemia event. And we also adjust the covariate by time-varying covariate quarterly. So for the statistic analysis in our study, we calculate the age stratified cumulative incidence for the macrovascular and the microvascular complications. And we use Kaplan-Meier survival curve to show the all-cause mortality, CV mortality, MACE, and the event for hypoglycemia. And we also use the time-dependent multivariate cost-proportional hazard model and adjust the covariate by ADCSI and the number of diabetes drug and the metformin-based therapy quarterly, and also adjust the other covariate. And for the result, totally we recruit 123,000 participants from the 2003, and 3% of them were classified as the onset age at 85 and more, and 62.2 of them were classified as the onset age in 40 and 64. For the baseline characteristics, for those older people with diabetes in older age, they will have higher DCSI and higher CCI, and they were more likely to be diagnosed in the inpatient setting. And while diagnosing diabetes for those with higher age, compared with the younger one, they will have higher risk for cardiovascular and metabolic disease and so on. And for the medications, since diagnosis for the higher age group, they will have the higher risk, higher probability to use the insulin. That may be due to they will be diagnosed in the inpatient setting, so they will have a higher probability to use the insulin, but they will have less likely to use the metformin and the sulfonylurea compared with the younger group. And for the cumulative incidence of the macrovascular complications, for those group with older age onset compared with the younger ones, they will have higher cumulative incidence for the cardiovascular disease, peripheral artery disease, cerebrovascular disease, and the foot disease. And for the cumulative incidence of microvascular complications, for those people with late onset diabetes in older age compared with the younger one, they have a lower risk, low probability to have the peripheral neuropathy and the retinopathy, but they have for older one, they have the higher risk for the neuropathy. And for the Kaplan-Meier curve for the outcome, for older group, they have the higher risk for the all-cause mortality, CV mortality, MACE, and the event for the hypoglycemia. And we use the forest plot to present the result for the adjusting covariate, and for the all-cause mortality, even for the follow-up period for 1 year, 3, 5, and 10 years, the older group have a higher risk for the all-cause mortality compared with the younger one. And even for the CV mortality, the group in older age also have the higher CV mortality compared with the younger one. And even for the MACE, it's the same condition. And for the event for hypoglycemia, it's the same that for the group in older age onset compared with the younger one, they have the higher risk for the high event of hypoglycemia. And our major finding show that the diabetes onset at older age are associated with the multimorbidity, and they would likely to be diagnosed in inpatient setting. They have the higher accumulation instance of the macrovascular disease and the low for microvascular disease except nephropathy. And they will be at high risk for hospitalization. They have the high risk for CV and the all-cause mortality. And after adjusting the covariate, they also show that for the older people, the onset at older age compared with the younger ones, they also have the higher risk for the event of hypoglycemia, the CV, and the all-cause mortality. And the older people typically present their presentation atypically. So maybe due to the atypical presentation, so the older people, if they have the diabetes, they don't show the typical presentation. For example, the polyuria and the polydipsia. So they are more likely to be diagnosed in the inpatient setting because of other complication or other disease. So for the diabetes onset at older age, they were more likely to be diagnosed in inpatient, and that's why I think that's why they will be used for the insulin higher. So we recommend the diabetes screen in older people. So the American Diabetes Association in 2020, they also recommend the people age 45 years and old should have the screen every 1 to 3 years. And for the treatment of the diabetes in older people, we also show that if older people they have the event of hypoglycemia, they will have higher mortality rate. And so in the past studies, they also show that in the intensive therapy in older people, they will increase the risk for hypoglycemia, and there's no significant effect for the MACE and the death. And the one famous study occurred in the NEJM also showed that for older people, they have the intensive therapy for glucose. They will also increase the risk for hypoglycemia and increase the mortality. So there are more and more recommendation to suggest the treatment goal for older people with diabetes. For example, for the American Diabetes Association and the International Diabetes Federation, they recommend the different treatment goals for older people according to their functional status. So they classify the older people with functional independent and functional dependent, and also classify them into frailty and dementia and the end of life care. So the target of the treatment for older people should be reset according to their functional status. So the strength of our study is that it's the nationwide cohort study, and we follow up for 10 years period. Its first studies explore the longitudinal clinical characteristics and the adverse outcomes among older people develop the diabetes in different age. And we also adjust the pattern of medications and the complications, and we adjust it quarterly. But however, there are some limitations in our present study. There are some important data not available in the national, the NHIRD. For example, we don't have the health behavior record, and we don't have the lab test result. And we define the newly onset diabetes according to the ICD code, but not the blood result. We also lack of the result of HbA1c, so we use the DCSI to serve as a surrogate of the optimal treatment for the diabetes. So we conclude that for the older people, we recommend to have the diabetes screen for older people. Maybe they present the diabetes in a typical presentation, and they will also have higher risk for CV and all-cause mortality. So it's recommended to have the diabetes screen for the older people. And we should screen the diabetes complication individualized in the older people. And the most important is that we should avoid the hypoglycemia and to use the safer medications to reduce the event of hypoglycemia. And we should watch out the multi-morbidity of older people with diabetes, including the other CV risk and the metabolic disease. And we should treat the older people with diabetes for their CV risk factors individualized while diagnosing diabetes. Thank you for your attention.
感谢3位讲者为我们带来精彩的演讲。现在为综合讨论时间，有请讲者来到台前，欢迎各位学员踊跃提问发言。Thanks for all the professors giving us the wonderful speeches. Now it's general discussion. Sincerely invited all speakers come to the stage.
Okay, dear everybody, we almost had additional 20 minutes to discuss. So I see there is several questions. The first is for Dr. Li. Okay, in your study, what parameters and cutoff were used to define the PCDS? For example, walking speed less than 1.0 meter per second.
Yes, thanks for this question, and I want to explain this definition of our PCDS. We define our physical performance by the AWGS. The walking speed was defined less than 1 meter per second, and the hand grip strength was defined according to the AWGS, 28 kilogram for men and 18 for women. And on the cognitive impairment, we adopt the definition based on previous study from FACE, introduced by Dr. Liang in this morning. We define all these cognitive impairment by MOCA. If any subdomain less than 1.5 SD, we will define the participant have cognitive impairment. If those participants have either cognitive impairment plus weakness or and slowness, we will define he or she is PCDS. Thanks.
Okay, thank you. The second question is still for Dr. Lee. In your study, can you further explain how to calculate the difference between groups? Is it based on baseline data or overall difference over the whole study period? And it seems the effect of intervention did not differ much between the 4 groups. Would you recommend to screen for PCDS or not before multi-domain intervention in community setting? Thank you.
Yes, I will explain how we calculate the difference between the treatment effect between robust and the PCDS group. We use the generalized linear mix model to adjust for the H6 site treatment and the interaction terms by PCDS by groups, just as robust, SIMD, MIND, and the PCDS, and the interaction terms between PCDS and treatment effect. So we could find the difference for the treatment effect from between robust and the PCDS. Well, we could look at the interaction terms. So we could find this comparison was all compared to the robust group. So it could not compare to, for example, the PCDS and the MIND. So we all compare to the robust group. So we could find the similar treatment effect between PCDS and robust in my presentation, in my findings. Just look at the right column, the finding. So all these findings were accounting for the overall difference, not the single time point, because we have five time points to check up. So we report the overall difference. And I please state again the last question.
Okay.
Yes.
It seems the effect of intervention did not differ much between the 4 groups. Would you recommend to screen for PCDS or not before multi-domain intervention in community setting?
Yes. So we designed these studies to examine if whether PCDS is a reversible condition, and from this study we could find yes. The answer is yes. PCDS is a reversible syndrome, so it deserves an intervention. And just as the previous finding, we just report the PCDS group had worsened functional outcomes. So if somebody have the worsened functional outcomes, and we could provide an intervention for them to reverse their functional outcome, why not? Why not we choose them and give them some intervention? So my quick answer is yes.
Thank you. It's important because it's reversible. The third question is for Dr. Zheng. In your proposed screening tool, there were different weights given to each other. what method would you apply to determine the scores?
Okay, and first, maybe I also answer the question 2, because the question 2 is asked for if it's needed to screen PCDS before our multi-domain intervention. So, because the multi-domain intervention in PCDS especially include cognitive training, I think it maybe sound different from the usual intervention like exercise and nutrition training. Because if in PCDS you didn't include cognitive training, maybe can to reverse the cognitive domain. So maybe if we have limited resource, maybe we have to this multi-domain intervention, maybe we can to use the screen tool to first to screen this high-risk group. Then if we have a different phenotype, it's just not high risk for PCDS, it's just risk for sarcopenia or risk for dementia. Maybe a different intervention program maybe we can offer. So the third question is how to develop this screen tool. And okay, I'm to say we use the univariate analysis to select the possible factors, and after you have the period below is significant stasis significance, and we put it into the binary regression model. And after the result, we have the beta coefficient. So we use how the ratio between these factors, and we change this coefficient into integer terms. Like if the beta coefficient is 2.1, then we maybe to change to 2. And if we 1.1, maybe we choose to only 0.1. So after change these coefficients, then we use the base for the sensitivity and specificity to build up these scoring systems. So it's about my answer to the question 3.
Okay, thank you. The next question is for Dr. Zhou. Do you notice any gender difference in the outcomes? If so, what do you think is the reason for the difference?
Oh, thanks for the question. But in our data, we don't see the difference in the gender, but only in the report from the Scotland. So I think for the in both gender, in male and in female, for the diabetes in late age onset, I think their condition is the same. Yes.
Okay. Oh, thank you. There's an additional question for Dr. Li. The new question. I would like to ask about your tiger research, because the research sites cover Taipei and the New Taipei City, Yilan and Hualien. The first question is, how does the team ensure that the research subject receive constant intervention? Because your article states that program details 16 structured 2-hour training. The first question can answer first.
Yes.
Thank you.
So before we start our tiger trial, we recruit all our researchers, including physicians and our research assistant and research nurses, to we'll give some physical training or cognitive stimulation trainings altogether to give them workshop to unify this process. And we also give some recording material online to educate them for regularly to unify the implementary the protocols. And for so we use this protocol to ensure our intervention is remain consistent around this intervention period.
There is another question to continue. Is it the same every time, or is it different? In addition, will the content vary depending on the region? And what is the role of the research nurse?
Yes. Our design include physical exercise or cognitive stimulation trainings. Their training difficulty were all the same. We remain the similar training intensity. We did not include this training difficulty because we believe we want to train our participants to nurture their healthy lifestyle. So we did not try to increase our training intensity because we could not believe the effect. They come back to the site only once per month, and we will gain some benefits for this less intervention frequency. So we decided to use the similar intervention intensity. So and on all of these intervention contents, we give them the principles. We did not limited the local teachers to give what kind of exercise or cognitive stimulation materials, but we give them principles. And on this study, research nurses did not involve in the training program. The training program, for example, the physical exercise will be maybe a exercise coach, maybe a physical therapy, PT. So they will not be the research nurse. Research nurse will be only take some, for example, the questionnaire or the blood sample. Thank you.
Okay, thank you. Excuse me, the tab is not age friendly enough for me. so,
Mr. Chairman, can I ask some questions?
Okay, thank you for Professor Arai.
I have a question to Bidi. Thank you very much for your nice presentation, Bidi. So I think the higher age onset is associated with cardiovascular outcome or mortality, of course, because it's age dependent. Do you have any data to show the effect of age without diabetes? And probably the odds ratio may be similar, or hazard ratio should be similar in terms of mortality or cardiovascular outcomes. So what is the contribution of diabetes to CV mortality and all-cause mortality in this cohort?
Thank you. Thank you for Professor Arai's good question. And in the past, we did the test for the older people with diabetes, late onset diabetes, and compare with those without diabetes. And we also see that the outcome show that they have the higher mortality and the CV event. So, but we try to adjust for the comorbidity, anything we can adjust. But maybe in the future we can try to do the comparison for those with and without diabetes in the both group. Yes, thank you.
Okay, and I think this is a little bit old cohort, like 2000 to 2013. So most of the patients were treated with sulfonylurea or insulin. So maybe the HbA1c level might be much lower than the current patient. Any data to show the effect of HbA1c on the outcomes in this cohort?
Thank you. And because of the limitation from the database from the National Health Insurance, we didn't have the data for the HbA1c. But I think usually in the inpatient service, if we find the high glucose level, usually in the inpatient service, we will start the treatment by insulin. So I think that's why the insulin rate is higher for the older people initially. But we don't have the data for the HbA1c. But we also, yes, we find the baseline characteristics for the DCSI, for the severity index for the diabetes. Yes, we found that for the older people, they have the higher level, higher score for the DCSI. So maybe they have the severe diabetes status for the older people when they were diagnosed. Yes.
Yeah, I think it's interesting to see the difference between the old cohort and the current cohort in terms of the prescription of DPP-4 inhibitor and also SGLT2 inhibitor, because those are more safer in terms of reducing the hypoglycemia event. So maybe it's very interesting analysis. I have another question to Eiju. You didn't see any difference in terms of value-based score by the intervention. What is the interpretation of your about this no difference in terms of value-based scores?
Yes, thank you, Professor Arai. Thank you for your questions. Yes, the value-based scores, we could not find the significant improvement among the PCDS group. I think maybe we have a problem just like the previous study Prediva in the Netherlands. Their study shows similar results from the intervention and the control group because of the author belief they have a very good quality of health care. So the intervention effects will be diminished in this good healthcare systems. So among the PCDS group, we could not find some significant improvement between intervention and the control. Maybe I believe maybe several reasons. One is the universal good quality healthcare to control the cardiovascular metabolic disease, and the other is maybe the vulnerable group. We only give them some integrated care for a short time, could not gain this rapid value-based score increase. So this is what I thought. But I think maybe Professor Chen has some different input, so he give me an eyesight. he So I got some message from my boss. He said maybe we divided too many groups, so we have limited samples, so it will limit the statistical efficiency, so we could not get the significance. So he thinks maybe this is due to the sample size, and we divide too many groups.
In other multi-domain intervention program like finger, people with severe cognitive decline had more benefit. It did what you found in the Tiger trial?
Yes, I believe our finding is compatible with the finger trial because our participants were multi-morbid old adults. They all had 3 or more chronic conditions. So compared to the this, we could find this finding from we enroll more complex older adults, more complex had more chronic conditions, and we could find all this improvement is very significant. So I think just echo the presentation from Dr. C.K. Liang in the morning. He indicated the participants enrolled in the study had poor enroll criteria such as lesser cognitive performance would gain some better clinical outcomes. But so in our Tiger trial, we enroll more complex participants in this study. So maybe it is.
Could you tell us the social implementation status of the Tiger trial? It's still research basis, so maybe you should apply this program to the community. Any situation or any status you can tell us?
Sure, I catch the eyesight from Professor Chen, so I
okay.
him answer this question.
There are 2 possibilities. It's true that government is hoping to promote the result of Tiger into the community. So there are 2 possibilities. One is from the National Health Insurance. When we were doing the press conference, the Director General of National Health Insurance Administration, he attended the press conference and commit he's going to increase the payment for the integrated care for this complex person, the complex older person who has more than 3 comorbid conditions. And so the first potential is from the National Health Insurance. And the second one is from, it will be a combination between National Health Insurance plus some long-term care budget. The long-term care budget, they have a specific funding for disability and dementia prevention. And in the past, they run separately. So we're hoping that by combination of the 2 different fundings, that we can get those things implemented in the community. And the current status, that is the whole Taipei City government is planning to implement our service to all the city hospitals. So which means you are going to cover all the district of the Taipei City. So I think it will be pretty fast that maybe next year we're going to see some hospital and the primary healthcare setting to replicate this model in the community to get everybody having more opportunity to receive the services. And of course, in the hospital I'm providing service now, we're going to have some new community sites to promote the Tiger protocol. So I think the next step for us is to have a community implementation with larger scale to trying to help the government to reduce the disability adjusted life years. Thank you.
How about your interpretation of the lack of effective on value-based scores by the Tiger trial?
In the original Tiger trial that published in the Lancet Health and Longevity, there's only 2 groups. So there's a case versus control. And at that time, the value-based metrics, if you only count the scores, it has improved significantly, especially in the Tier 3. Tier 3 represents the long-term benefit, the long-term health service benefit. But in today's work, Weizhu did another sub-analysis. So it's not the, he is going to publish more papers. So in today's presentation, he divided the original Tiger data into 4 groups. So there will be robust, mild, signed, and PCDS. So because of 4 groups, so the comparison during the 4 group, the statistic power will be reduced. So I think there will be sample size issue because the original Tiger has only around 400 cases. So I think that's the major issue that we don't have enough statistical power.
Thank you.
Okay, thanks for Professor Arai's question and comment. Is there any question or comment here or online? Oh, Professor Xu.
Thank you. I have a question for Dr. Zhou. I'm very impressed for your research results using the National Health Insurance Database. And I strongly agree with Dr. Arai said that maybe we have to compare the diabetes with and without diabetes because the aging effect is very strong. And the second one is that I want to know, because your cohort you follow for about 10 years, I want to know how you deal with the death, the mortality, because when you measure the macrovascular disease in the elderly, we have to consider the mortality issue. Do you use the competing risk to adjust your survival model? This is the first question. The other one is that when I see your result, the nephropathy is not significantly positive in the elderly. How do you interpret this result?
Thanks for Dr. Xu's question. For the first question, if the participant passes away, he or she dies, I think he will be censored. So for the cumulative incidence rate, they will be censored and they will not be included in the calculation for the incidence, cumulative incidence. And for the second question is that
nephropathy.
Oh, nephropathy, because there are other maybe there are other strong attributed factors for nephropathy, for hypertension or other disease. Maybe they come from the hypertension or other reasons.
Is it possible that when you recruit the elderly people, they originally have the impaired renal function? Because I see your metformin use proportion is lower in the elderly people. So maybe for the elderly, for those who are older than 75 or 85, their renal function has already been in the stage 4 or above. So they reduce the use the metformin. The lower use metformin maybe indicate that they have potential impaired renal function. Is that the reason?
Probably, we thought probably it's not the case because we're using the National Health Insurance data. And the previous study have shown that for the elderly diabetes, the mortality risk of macrovascular is much higher compared to the microvascular because the microvascular, usually when it was developed, it takes time. It needs longer incubation period to reach a solid outcome. But for the elderly onset diabetes, usually they are not having enough incubation period to develop the outcome. But not for the macrovascular. Macrovascular can, once you have diabetes, no matter you're younger or older, the macrovascular mortality risk is already high, even in the first year or second year. So maybe that's the nature of the macro and microvascular complication. And we're also curious that why the metformin use in Taiwan, especially for those elderly person, is not high. There's no GFR data, but if we check the previous diagnostic code, there was no specifically high nephropathy prevalence. So I think it's just physicians prescribing habit that in Taiwan, well, although we always say metformin first, but that is not the case eventually. So yeah, but in this study, we stratify the treatment pattern into metformin-based, insulin-based, or sulfonylurea-based. And we're now having a new study trying to using more complex modeling to explore whether the drug class shift during the treatment course can also result in different outcomes. It's a very, very complex real-world research. So yes, we're hoping to get more data, and including the DPP-4 inhibitors and other, or GLP-1, the SGLT2, something. All those things are related to diabetes care, the new drug with relatively lower risk of hypoglycemia. But we speculate that DPP-4 inhibitor may be significantly better than others because GLP-1 and SGLT2 inhibitor are not really, the profile is not very good for elderly person. But one common limitation for us to examine the association is the lack of functional status in the national health insurance data. We don't know how much disability can change the model and to increase the mortality risk. That would be the universal limitation. Maybe someday we need to go to Korea using their data. Korean national health insurance data include functional performance. So maybe we can gather those research questions and go to Korea doing some analysis. Thank you.
Okay, thank you. Because of the limitation of time, I have to close this section. Thank you for your attendance. Then our colleague will pronounce some information.
感谢各位踊跃的提问及发言。现在为茶休时间，场外备有茶点，欢迎各位享用。下一场演讲将于3点30分开始。Thank you all for your participation and comments. The next session will start at 15:30. Thanks for your cooperation. 各位来宾，大家午安，欢迎莅临身智衰退症国际研讨会。接下来有请国家卫生研究院高龄医学暨健康福祉研究中心许志成执行长为我们主持。Good afternoon, ladies and gentlemen. Let's welcome Professor Ji-Chen Xu, the CEO of Center for Geriatrics and Welfare Research of National Health Research Institute, to host the following session.
Thank you. Ladies and gentlemen, welcome to this section. Good afternoon, everyone. Today, this section is the last section, but I think it's the most interesting and the most important one for this today's conference. I want to introduce 3 speakers in this section. The first one is Dr. Zhong Zhiping. She graduated from School of Medicine, China Medical College, and she has a PhD degree from Institute of Clinical Medicine, National Yangmin University. She served clinical service in medical centers since 2006, including critical care of acute stroke, prevention of stroke, and the management of vascular dementia. Her research interests include explore the role of several small vessel disease to elucidate the mechanism of the posterior circulation stroke, and also to discover the influence of the cerebral venous insufficiency. She is now an attending physician in the Neurological Institute, Taipei Veteran General Hospital, and she is also the professor of the National Yangmin Jiaotong University. Today, she wants to give us a talk about the brain age and the small vessel disease in Physico-Cognitive Decline Syndrome. Let's welcome Dr. Zhong.
Good afternoon, and in case, good morning and good evening, ladies and gentlemen. And thank you, Professor Xu, for the introduction. This is my topic, brain age and small vessel disease in Physio-Cognitive Decline Syndrome. I believe that the criteria and the definition of PCDS have been extensively discussed in previous talks, so I will briefly remind you about the definition and the rationale behind the definition of PCDS. PCDS is a combined of MIND, slowness or weakness, and the CIND, greater than 1.5 standard deviation below age, sex, and education matched norms in any cognitive domain. And these operational criteria is set basing on several facts derived from our previous studies. These facts include the first of all, physical frailty has heterogeneous clinical and neuroimaging characteristics, and it is the mobility frailty, slowness or weakness is the frailty subtype that was associated with cognitive impairment. And before we have known the associated cognitive trajectory of physical frailty associated cognitive impairment, we should consider all cognitive domains in frail subjects at the present time. So under this definition, the prevalence of PCDS was around 11 to 30% in Taiwan or in Japan, and it could predict all-cause mortality in people aged more than 65 years and predicts incident dementia and incident disability. So we believe that PCDS could be an ideal phenotype of accelerated aging and might serve as the critical point toward unhealthy aging. And furthermore, we think it will be a very good study target to study, to evaluate the pathophysiology of accelerated functional decline in the elderly. So the present study used the population from the ELAS cohort. This cohort recruited community-aware persons aged greater than 50 years without major disease, disability, or dementia. And all of them has received comprehensive cognitive and physical evaluations, and also high-resolution 3D brain MRI. So let's step into my topic. What is the brain age, or what is the brain biological age? It is a common observation that some people will age faster than the others. So from physicians or researchers' perspectives, and I believe that all of you will agree that an individual's biological age might be better than the chronological age to reflect an individual's age-related healthy status. So we use the machine learning to feed them with big brain MRI data and train them to predict the age. And this brain age measurement has been developed, and several evidence have shown that this measured brain age might be a novel biomarkers of brain biological age. So with this method, every individual could have a measured brain age, and if this measured brain age is older than your chronological age, you will be deemed as having accelerated brain biological age, or you have an advanced brain age. And several clinical studies have shown that if you have an accelerated brain biological age, you are, have poorer cognitive decline in the aging status, or you are more subjective to several neurodegenerative disease like Alzheimer's disease and even mortality. So with this method, in addition to a major brain age, you will have a brain age gap, which is the difference between your major brain age and your chronological age. So this brain age gap has been used to evaluate how neurological disease interact with the normal brain aging process and to predict clinical outcomes in this disease. So the first aim of this talk is to evaluate whether accelerated brain aging is involved in the pathophysiology of PCDS. There were 1,193 ELAS participants included in the present studies. All of them have eligible brain MRI to be analysis. And we divided them into 4 groups. There were 198 participants with PCDS, and PCDS, we can see that at baseline PCDS participants were older and less educated and had poorer cognitive function. And we trained the machine to, and we fed them with a big brain MRI data with the gray matter features, and then derive a very good model with the performance of age prediction is very good, and we use this model to measure individuals' brain age. And the results show that PCDS had advanced brain age compared with the robust MIND and CIND groups in the total population. And there seemed a trend of age interaction effect on the association between brain age gap and the MIND compared with the CIND and the PCDS. We can see that in MIND, if the subjects were older than 65 years, their brain age gap was greater than the robust, but not in MIND participants with age less than 65 years. But PCDS had advanced brain age compared with robust group in the total population and in either age groups. And then our second aim is to evaluate whether accelerated neurovascular aging is also involved in the pathophysiology of PCDS. I will briefly introduce you about the details, the brain microvessel, the information about brain microvessels. Small vessels are composed of arterial, capillaries, and venules, and their function are to regulate and maintain adequate cerebral blood flow, regulate the BBB, and even CNS lymphatic system. And with aging, there are a lot of pathologies developing in the small vessel. And these age-related pathology in small vessels are now acknowledged as important etiologies of dementia, gait disturbance, and stroke in the elderly. And these are common pathologies in small vessels. These pathologies include tortuosity, venous collagenoses, decreased microvascular density, atherosclerosis, lipohalinosis, arteriosclerosis, and amyloid angiopathy. And a lot of studies, including cross-sectional or longitudinal ones, have proved that the presence and the severity of small vessel disease are associated with geriatric syndromes, include dementia and gait disturbance and disability. And the researchers face the problems that only the pathology at late stage of disease are available. So we have little clues to the initial and early pathophysiology of disease. And thanks to the advance of technology, now we have a high-resolution neuroimaging. We have the MRI to evaluate the details in the brain at a symptomatic or even earlier stage of disease. So now we use the brain parenchyma lesions, which are presumed to caused by small vessel disease, small vessel pathologies, as the markers of small vessel disease. And these markers are recent small subcortical infarct or lacunar infarction, white matter hyperintensity, lacune, dilated perivascular space, or microbleeds. And again, we use the ELAS study population, and we have these small vessel disease markers from the brain MRI. And we will measure the small vessel disease score in each participant. The score is summed by whether there is a presence of severe white matter hyperintensity, whether there is a presence of lacune, and whether there is presence of more than one cerebral microbleeds. And we defined small vessel disease as small vessel disease score greater than 1. So in the study project, we can have 124 participants with small vessel disease, and the baseline showed that people with small vessel disease were older, also less educated, having more prevalent hypertension, diabetes, and dyslipidemia. And the results showed that the prevalence of small vessel disease was indeed different among 4 groups. And PCDS had the highest prevalence of small vessel disease. And since we know that PCDS were older and maybe having more prevalent vascular risk factors, so we performed the multivariate analysis to adjust these potential confounders. And the results show that small vessel disease was significantly associated with PCDS. These associations were independent of age and the presence of vascular risk factors, with an odds ratio of 2.3. So these preliminary data unpublished data led to the conclusion. PCDS, which is a clinical phenotype, helps identify who are at risk of dementia, disable, or mortality. Also shows accelerated brain gray matter aging and accelerated neurovascular aging. And since PCDS is reversible, it might serve as the critical point toward unhealthy age. Brain age and small vessel disease are shown in our projects might be involved in the pathophysiology, might also be the potential treatment targets for healthy aging. And I would like to thanks to my cooperators, Zhou Kunxian, Pei Lin, and Zheng Yuan. They embody our ideas. And also Li Weiru, who runs and maintains the ELAS cohort. These are very precious data for Taiwan geriatric research. And Chen Lianggong, who makes everything possible. Thank you very much.
Thank you, Dr. Zhong's excellent presentation. If you have any questions, please just wait until all the three presentations end. Now, let me introduce the next speaker, Ms. Lü Wanxuan. She has a master's degree in clinical pharmacy from National Taiwan University, Taipei, Taiwan, and she is currently a PhD student in focus on epidemiology in University of Toulouse, Paul Sabatier, France. Ms. Lu serves in the SPIRE project at Genetopo of Toulouse, the WHO Collaborating Center for Frailty Clinical Research and Geriatric Training. Her background is within the clinical pharmacy and the public health, specializing in epidemiological, pharmacoeconomics, and the healthcare utilization related to the older population. Since 2019, she has been engaged in study on biomarkers of frailty, physical and cognitive impairment. Her current focus is on the biological mechanism of intrinsic capacity and their long-term impact on functional outcome during the aging process. Ms. Lu's today's presentation topic is the ICOP as a screening instrument of Physio-Cognitive decline syndrome. Compare Taiwan and France comparison. Let's welcome Ms. Lü Wanxuan.
Thank you, Professor Xu. Good afternoon, everyone. Thanks for organizing this outstanding conference about PCDS. I'm very fortunate to be part of it. So I'm Penny Wanxuan Lü. I am the researcher of Genetopo Toulouse University Hospital in France. And the topic of my presentation is whether ICOP stage 1 can serve as a screening instrument of Physio-Cognitive decline syndrome. So after attending the conference for the whole day, I think you may already have a certain background knowledge about PCDS. So in this presentation, I will first focus on the concept of ICOP and ICOP stage 1 instrument. Then I will present an analysis using the ICOP indicator to identify PCDS in the French and Taiwanese cohort. First of all, I would like to share a story about the neighbor of my colleague. This is Monsieur Gascon. He is a 90-year-old man who lives with his wife in a small town nearby Toulouse. He has several chronic diseases. However, under the medication treatment, all these diseases is well controlled. But Monsieur Gascon is still unhappy. Why? This is because after he has these chronic diseases, he gradually loses ability for engaging his hobbies, driving and riding a bike. You probably have heard similar story of Monsieur Gascon in your working experience or your family. All this story reflects the potential problem in our current healthcare approach among older adults. Nowadays, healthcare follows the disease clinical pathway. In the case of Monsieur Gascon, we first discovered his blood pressure was elevated, so we provide further assessment and diagnosis. Then we offer anti-hypertensive agent and surveillance. And then we found another problem of blood sugar. We follow the same strategy, making assessments, treating by medication, and followed by biomarkers, and so on. All these states of disease control are important, but none of them target on the functional ability, the ability that allows older adults to be and do what is meaningful for them. To address this issue, the World Health Organization has launched integrated care for older adults since 2017. The integrated care for older adults, or ICOs, are to provide a person-centered, functionally based approach. In brief, ICO completes 5 states of care. In the state 1, the intrinsic capacity of the individual is regularly monitored in primary care. About this intrinsic capacity, I will provide more detail in the following slides. Once the health professional detect the abnormal intrinsic capacity of the individual, they will further provide the in-depth assessment in stage 2. And if needed, a personalized care plan will be proposed and implemented with referral to specialists and support from the community and social service. As mentioned earlier, functional ability is for people to be or do what is meaningful for them. Functional ability is determined by intrinsic capacity and surrounding environment. Intrinsic capacity is defined the composite of all functional capacity of an individual. Theoretically, intrinsic capacity changes across the life course. It reaches the peak in the beginning of adulthood and declines gradually during the aging process. Once intrinsic capacity is lower than a certain threshold, people start presenting frailty, disability, and other clinical outcomes. There are several ways to operationalize intrinsic capacity. The most common way is to use 5 functional domains: cognition, locomotion, sensory, vitality, and psychological. In WHO program, intrinsic capacity is constructed by 6 domains. The sensory capacity is assessed by visual capacity and hearing ability, respectively. No matter which definition, cognitive and locomotive capacity are considered the key domain of intrinsic capacity. So back to the ICO. The ICO program has been implemented globally. So far, WHO has started 7 pilot studies, in 7 different countries. And one of pilot studies is launched in the Occitanie region of France by Toulouse University Hospital. In addition, several countries also implemented their ICO program, including Taiwan. Since 2020, the Health Promotion Administration of Taiwan has launched a national ICO program to prevent functional disability and age-related chronic disease among the older adults. In the ICO approach, Stage 1 plays a critical role. The Stage 1 instrument should be comprehensive, feasible, and quickly applied in primary care. In addition, it should have the balance between specificity and sensitivity, like enough to identify people with the risk of functional decline and avoid increasing the burden on healthcare system. In the Stage 1 instrument, each domain is assessed by 1 or 2 simple tasks or indicators. If older adults fail to complete the task or present a condition corresponding to the indicators, they will define as impairment in that domain. Here, I just want to give you an idea that ICO screening instrument is related to adverse outcomes. This study comes from our research team in Toulouse. We found that higher number of intrinsic capacity was associated with incident frailty and disability in older adults. This is the result of another study by our team, which showed that people who fail the cognitive test in ICO stage 1 have a lot higher risk of incident dementia. So in summary, ICO stage 1 instrument is used to identify older adults at higher risk of functional decline. And this screening instrument was associated with adverse outcomes, including frailty, disability, and dementia. So an interesting question arises. Can we use ICO screening tests for cognitive and locomotor impairment to identify older adults with PCDS? To address this research question, we conduct a comparative study between France and Taiwan. For the French analysis, we retrieved the data from a randomized controlled trial called MAP. The original objective of MAP study is to investigate whether 3-year intervention can prevent cognitive decline among commonly diagnosed older adults. The MAP intervention include the daily omega-3 supplementation and multi-domain lifestyle intervention. MAP study enrolled participants aged 60 years above and who had at least one risk factor of cognitive decline, including spontaneous memory complaint, limitation in at least one instrumental activity of daily living, or slow gait speed. The Taiwanese analysis used the data from the Health Promotion Administration ICO program. All the participants in the program is aged 65 years and above, living in the community, functional independent, and dementia-free. This table summarizes the PCDS measure in our analysis. The physical impairment was assessed by 5 repeated chair rise tests. In the chair rise test, participants were required to stand up from the sitting position with their arm floating across the chest, and then repeatedly stand up, sit down movement as quickly as possible. The time complete the 5 stand was recorded. In the French cohort, we applied 14 seconds as a cut point. That is, participants failed to complete 5 stand race within 14 seconds were considered as physically impaired. But for Taiwanese cohort, we provide 12 seconds instead of 30 seconds. This is because Asian older adults tend to have better physical performance than their Western counterpart. For cognitive impairment, both cohorts was measured by 2 cognitive tests, a 3-word recording text and time orientation. In a 3-word recording text, the participant was asked to memorize the name of 3 objects and then recall them after several minutes. For the time orientation, the participant had to answer the full day of the interview, including the year, month, day, and the day of the week. Participants who fail to answer either of these 2 tasks will consider as having cognitive impairment. So based on the presence of physical and cognitive impairment, we can classify participants into 4 different phenotypes: PCDS, mobility impaired no disability, cognitive impaired no dementia, or robust. About the time point, we have multiple measurement of function in MAP study. So for the French part, it's a longitudinal data. And for Taiwanese analysis, all the participants only have single measurement for their function. So move on to the result. This table displays the PCDS preference according to different definition and cohort. The first column is based on the original PCDS definition from the phase study in Taiwan, which is presented by Dr. Liang in the morning section. We can use it as a reference. The middle column is the result from the French MAP study, and the last column is the result from Taiwanese ICO program. We can see that the PCDS preference based on the ICO State 1 measure vary across the cohort, indicating the great differences in the characteristics between these two populations. It seems that the PCDS prevalence is much lower in Taiwan, probably owing to their younger and healthier population. It's worth noting that the cognitive impairment rate in the MAP population is very high. It is because all MAP participants had at least one risk factor of cognitive decline at the study enrollment. Here is a comparison of demographic according to PCDS phenotype. In both French and Taiwanese cohort, we found that people with PCDS had older age compared to the other three groups. Since we have longitudinal in MAP, we would like to know the longitudinal change of PCDS over time. So this slide presents the evolution of PCDS phenotype over time. According to the ICO State 1 measurement, around 12% of MAP participants have PCDS at baseline. And after 3 years follow-up, around 15% of population have PCDS or dementia diagnosis. We also performed analysis among people in the control group, which provides similar results. Here you can find that the MAP participant was very fit. Not so many people develop PCDS or dementia after 3 years. But we should also keep in mind that MAP is not a population-based cohort, so this result may not be generalized to other populations. This table presents the transition of PCDS phenotype over 3 years in MAP control group. We divide people into the PCDS and non-PCDS group according to ICO State 1 indicators. The non-PCDS group, including those who only have physical impairment, who have only cognitive impairment, or who were robust. After 3-year follow-up, about 2/3 of individuals with PCDS initially refers back to non-PCDS status, and about 30% of people without PCDS at baseline develop PCDS or dementia after 3 years. Finally, we would like to know whether the MAP intervention can impact the PCDS status over time. This table displays the association between MAP intervention good and the PCDS phenotype using the multinomial logistic regression. The outcome was the cognitive status after 3 years intervention. After adjusted age, sex, education level, and the baseline PCDS status, we did not observe the association of MAP intervention group with dementia and PCDS status. This result was expected since in our previous study, we did not observe any intervention impact on the decline of cognition and physical performance among the MAP participants. So, in summary of our finding, we found that the PCDS preference according to ICO State 1 instrument vary across different populations. And among MAP participants, about 2/3 of PCDS individuals refers back to non-PCDS status, and around 13% of non-PCDS subjects develop PCDS of dementia over 3 years. And finally, no association between MAP intervention and PCDS phenotype was observed. So back to our initial question, can ICO State 1 be used as a screening instrument of PCDS? I think this question is still open for discussion. We can rethink this question from the fundamental concept of PCDS. As Professor Chen mentioned in this in the morning section, the PCDS include two important elements. The first is PCDS should be reversible. Second, PCDS should be a good predictor of adverse outcomes, including incident disability, dementia, and mortality. So according to our previous finding, most people with PCDS defined by echo indicators can reverse back to non-PCDS status. But the second element should also be considered when we answer this question. So far, we have mentioned 3 different ways to assess physical impairment, that is, increased chair rise time, slow gait speed, and lower grip strength. They actually deliver very different message in terms of physiology. The chair rise time evaluates the lower extremity muscle strength of the human body. It examines an individual's ability to transfer from a sitting to a standing positions. This movement depends largely on balance control, muscle mass, and muscle power of the lower limbs. Gait speed, on the other hand, is known as a functional vital times. It is because walking relies on multiple multi-movement and high level of movement control involving executive and memory function in our brain. Therefore, walking slow is not just a problem with legs. It actually an evolving clinical sign of disintegration between the body systems. And regarding grip strength, although it's a measure of strength of hand, it actually correlated with the muscle power of the whole body. The growing study have demonstrated that the grip strength was strongly associated with long-term survival. In addition, grip strength is also served as an indicator of vitality in intrinsic capacity. In the previous slide, I didn't have enough time to introduce vitality. To make the long story short, previous study has suggested that intrinsic capacity comprises 2 levels, an underlying capacity and the expressive capacity. Vitality is underlying capacity that represents the complex and dynamic biological chain inside the body. It's like the heat source inside a volcano. And the express capacity, the remainful domain, is all affected by vitality. When the express capacity are impaired, they can be easily observed through clinical evaluation. And this like that lava flow or the ash cloud we can see during the volcanic eruptions. Therefore, as an indicator of vitality, we can say that the grip strength mirrors the physiological reserve of an individual. So in summary, these 3 indicators represent the physiological function range from general to loading specific. So the question should be, which level of physiological fever we would like to capture when we're screening PCDS? Similar issue has been discussed in the topic of motoric cognitive risk syndrome. Like PCDS, motoric cognitive risk syndrome, or MCR, also describes a concurrent physical and mental impairment. MCR is defined as having slower walking speed and subjective cognitive complaint, and it is considered as the pre-dementia stage. In this article, the author compared the MCR individual defined by walking speed with those defined by chair rise time. They found that the MCR individual identified by these 2 tests have different cognitive profile. So they further suggest that chair rise time should not define MCR. Here is the main result of the article. In brief, there is a slight overlap between people who had poor performance in chair rise tests and those who experienced slow walking speed. Therefore, if MCR was assessed by chair rise test, 76 participants who walk slowly but have normal chair rise time will not be considered MCR. But these 76 participants has a risk of mild cognitive impairment. On the other hand, 39% of participants who performed poorly in chair rest test but walked normally did not show the higher risk of cognitive impairment. So in other words, using the chair rest test to define MCR will misidentify people at risk for cognitive impairment. So back to our initial question again, we mentioned that the chair rest test is a specific indicator of low limb function, and it is not a better indicator than gait speed in terms of cognitive outcomes. So if dementia is one of key outcomes we would like to prevent through early identifying PCDS, or if we think the combined cognitive and physical impairment in PCDS indicated an ongoing multi-system physiological change, then the chair rest test may not be a suitable screening tool for PCDS. So this is a take-home message for this presentation. After listening to this lecture, I hope you can have a general knowledge of ICOPE. This important global program provides a functioning-based approach to maintain optimal function level in older adults during the aging process. Nowadays, both Taiwan and France have already implemented the ICOPE program. Second, our results support the ICOPE Stage 1 screening tool as a good indicator of reversible physical and cognitive impairment. Finally, chair rest test in ICOPE Stage 1 cannot be a screening instrument of PCDF if our goal is to predict dementia or identify early multi-system physiological change. Before finishing this presentation, I would like to thank Dr. Pond, Professor Chen, Ms. Meng, and Professor Xiao for supporting the analysis of Taiwanese ICOPE program. Also, I would like to thank my research team in Toulouse, Dr. Emmanuel Gonzalez, Professor Philip Barreto, and Professor Bruno Fellas for supporting the data and material for this presentation. Thank you for your listening. I'm happy to take any question in the end of section or through email.
Thank you. Thank you, Ms. Lu. Thank you for your interesting presentation. Now I want to introduce our third speaker, Dr. Roman Romero Otuno. He graduated from the School of Medicine, University of Barcelona, Spain. He is a member of medicine in Royal College of Physicians of London, UK, and he got his PhD degree in geriatric medicine in Trinity College of Dublin, Ireland. Dr. Roman's current research focus on the key direction is toward the better understanding and modeling the concept of frailty in older adults and translating knowledge into improvement to the care of the older people. His research has generated many new tools for the operationalization of the clinical concept of frailty in ways that add value to practice and the research. Today, Dr. Roman wants to present a topic entitled Association between Motor and Cognitive Performance in the Irish Longitudinal Study on Aging. Dr. Roman, please.
Thank you very much for a very generous introduction, and I am delighted to be presenting today from Dublin in this international symposium of Physio-Cognitive Decline Syndrome. And I would like to, first of all, thank you very much to the organization and for inviting me to a very exciting symposium. So in relation to this talk, I have no conflicts of interest, and I would like to start by introducing you to the Irish Longitudinal Study on Aging. This is a nationally representative sample of over 8,500 participants that has now been running for a little bit more than 10 years. It was established in 2009, And it is without a doubt the most comprehensive study of aging ever conducted in Ireland. The Irish Longitudinal Study on Aging has a wide range of working themes and working groups, and the TILDA study has collected a broad array of research themes, including biomarkers, nutrition, physical health, vision, cognition, mobility, frailty and resilience, and I am delighted to coordinate the Frailty and Resilience Working Group in this very rich research environment. In addition, we have started new studies based on the TILDA dataset and clinical cohorts. And an example of that new research is the Frailmatics program, of which I am the principal investigator as the President of Ireland Future Research Leader Award 2018. This program started in 2018 and it's scheduled to finish in 2024. And is looking at the concept of frailty as multi-system physiological dysregulation and vulnerability to stressors. And our goals are to work within a truly transdisciplinary research environment to identify new frailty biomarkers, perform clustering and precision phenotyping of the population-based and the clinical-based cohort, and discover new integrative models of multiple system deregulation. For this particular study, we are focusing on three main domains, the cardiovascular or neurovascular, the neurocognitive, and the locomotor. And of course, for the physio-cognitive decline syndrome, the neurocognitive and the locomotor systems are of very high interest. So this program is funded by Science Foundation Ireland. Just to give you a quick overview of the way TILDA has organized the data collection. So in 2009-10, we had the first wave of assessments, and that included a computer assessment personal interview, a self-completion questionnaire, and a detailed health assessment, which happened in a dedicated health center to which people had to attend in person. Now, every wave of the study happens around every 2 years, and only every second wave we have a detailed health assessment wave. So that happened again at 4 years in wave 3 and was due to happen last year at wave 6. Unfortunately, it's been delayed due to the COVID pandemic, but the research team and the management are working very hard to get modified health assessment up and running in 2022, and things are going very well. I just give you a high-level description of some of the CAPI cognitive measures that the TILDA study included. You had global cognitive function tests, such as the mini-mental test examination, and also you had verbal memory, prospective memory, and verbal fluency tests. In case of the verbal memory, participants underwent a 10-word list learning and recall. Prospective memory, such as remembering to perform an intending action. And for verbal fluency, they underwent animal naming tasks. In the health assessments, those are participants that came in person to the health center. They also underwent pen and paper tests, and one of the global cognition assessments was the Montreal Cognitive Assessment, the MOCA. As you know, it measures global cognitive function. It's a little bit more sensitive than the MMSE, particularly in deficits of executive function. And it assesses visuospatial ability, praxis, naming, memory, attention, language, and orientation to time and place. And it has been said that it has a better ability to discriminate mild cognitive impairment from normal controls. In the health assessment center, there were other cognitive measures performed. One of the interesting ones looking at executive function was the Color Trails Test 1 and 2, also abbreviated as CTT. So it's a paper and pencil test. It assesses visual speed of processing with the CTT1 and executive function with the CTT2. So in CTT1, the participant is asked to connect the numbered circles 1 to 25 sequentially. And on CTT2, it has to connect sequentially, but alternating the colors. And you can see here in this video tilde participant undergoing the CTT2 in the presence of the health center nurse. There were also computer-based cognitive assessments in the Health Assessment Center. A very interesting one is the choice reaction time, abbreviated as CRT. This computer-based test is designed to measure reaction time, which is the speed of processing. Two choice tasks are there, whereby participants must press yes button or no button, depending on which word appears. And there's two separable components, the time to plan the move, which is the decision time, and the time to make the move, which is the motor time. And you can see in the video an illustration of how the participant would interact with the computer to perform the CRT in the presence of the research nurse in the Health Assessment Center. Another very interesting computer-based cognitive test is the sustained attention to response task, which is abbreviated as the SART. This is a computer-based measure as well, requires the button press, where participants are required to press a button when they see the numbers 1 to 9, which appear sequentially, except when the number 3 appears. And when the number 3 appears, they have to step away from the button and not press the button. So the test is testing the ability to maintain goal-directed focus on repetitive stimuli in the absence of any novelty. So indeed, testing your sustained attention. And it measures lapses in cognitive control, leading to perseveration and overlearned responses. And the time on task effects are linked to failure to maintain alertness. So you can see in the video how the participant was pressing the key every time numbers appeared, except for number 3. In the Health Assessment Center, we also had objective mobility measures, including the usual or preferred gait speed, and also cognitively loaded gait assessments. We were recording these gait assessments using the GateRight automatic platform that actually records not only gait velocity, but also a lot of temporospatial parameters of gait. You could see in example 1, the lady undertaking the preferred gait speed or usual gait speed, and the second lady was reciting every second letter of the alphabet as she was walking. A STAR health assessment mobility measure is the time get up and go, which has been already presented here. And it consists of rising from the chair, walking 3 meters in a straight line, turning around and getting back to the chair and sitting down again. And I'm glad to see that in Asia, the 12 seconds or less was adopted as a cutoff as well, because in our studies, we also consider the 12 seconds as the Irish cutoff, perhaps suggesting that the Irish population are also a little fitter than the rest of Europe. So mobility and physio-cognitive decline syndrome, what is the longitudinal story? We have, of course, the privilege of working with the Irish longitudinal study data set, and it is a population-based study which addresses some of the limitations that other researchers have with non-representative populations. So indeed, the bidirectional longitudinal associations between mobility and cognition in older adults are quite poorly understood, although there's quite interesting advances, as we are hearing in this very exciting symposium. In this study, we studied the temporal associations between time get up and go, in this case, and 5 cognitive function domains. The MoCA, which is global cognition, processing speed, choice reaction time, animal naming as verbal fluency, color trail test as executive function, and the sustained attention to response task. And we used 8-year longitudinal data in the TILDE study. And this work was led by Dr. Peter Hartley, who is an associate, a postdoctoral researcher with the Frailmatics study, and very successfully conducted his PhD in the University of Cambridge. And I'm going to present some of the results that he came up with the TILDE study. For this particular study, we designed 2 longitudinal samples. So sample A was utilized for cognition as a predictor of mobility over an 8-year period. And sample B was utilized for mobility as predictor of cognition over 4 years. And of course, since cognition was established with the MOCA test was only done in the health assessment, so we only had 2 time points over 4 years. Whereas for time get up and go, we had information at every wave, because this assessment was also conducted at home, not only in the health assessment. So there is an 8-year longitudinal frame. The numbers are big. We are really excited with the numbers of participants. So for sample A, in this case, we had a final sample of 4,913 tilde participants. And for sample B, we had 3,675. So sample A and sample B had similar age range. So we are talking about community dwelling older people in Ireland, about a mean age of 62, 54% were females, and they're generally quite well educated with a proportion of higher level education, which can be as high as 35 to 38%. And the prevalence of frailty and significant morbidity is reasonably low, with average time get up and go times that can be quite quick, around 8 to 9 seconds. And you have here in the table the rest of the descriptives of these samples. So for this analysis, we performed marginal effect plots. And in this case, you can see here the 8-year analysis of 5 linear mixed effect models showing the effect of cognitive domain scores on time and get up and go times. So for this analysis, the cognitive measures were standardized, and the groups were based on standard deviations above the sample mean at baseline on a standardized score. So you see, as time progresses on the x-axis from 2, 3, 4, 5th wave of the study, so when the baseline cognition was at least 2 standard deviations above the sample mean at baseline, which is the yellow line at baseline, so the time get up and go would have been quite quick, around 9 seconds in every case. But as time progresses, those who were above 2 standard deviations of the sample mean at baseline seem to progress quicker in their mobility decline. So much so that a lot of these yellow lines did hit the threshold of 12 seconds in time get up and go, which at that point would be classified as a clinically significant mobility impairment. And that seemed to happen more obviously with sustained attention task, the SART test, and the choice reaction time, which is the second computer-based test. To an extent, it also happened with global cognition, the MOCA test, but it did not quite happen with verbal fluency test and color trail test, which it is an interesting observation. Of course, these models were already adjusted, so there are marginal plots. So they are adjusted by age, sex, body mass index, grip strength, independent activities of daily living, fear of falling, number of medications at wave 1, number of chronic conditions of wave 1, the baseline time get up and go, the level of education. So these models are very robustly controlled, and these are the marginal effect plots. On the other side of the direction, so this is showing the marginal effect plots of the 5 linear regression models that we use to show the effect of time get up and go times at wave 1 on cognitive domain scores at wave 3, and where higher cognitive scores represent poorer cognitive function. So you could see in this case the time get up and go in seconds at wave 1 on the x-axis, going from 5 seconds to 25 seconds. And on the y-axis, you will have the predicted general cognitive score at wave 3, which is 4 years later. And the steepness of that line gives you an insight or a suggestion as to what was the more strong effect. And in this case, you can see processing speed, which is the choice reaction time computer-based test, as perhaps showing the higher steepness over time. And perhaps also suggestion that sustained attention and verbal fluency had some effects as well. Although in the statistical analysis, it seemed like sustained attention and processing speed were most statistically significant. However, the effect sizes on the cognitive scores were very modest, so very small and likely insignificant clinical effect sizes in the models that were already adjusted by age, sex, body mass index, grip strength, disability, fear of falling, medications, chronic conditions, standardized cognitive scores at wave 1, and education. So how do we interpret these results? So first of all, we can say that associations were statistically significant in both directions. That is, cognition predicting mobility and mobility predicted cognition. However, cognition predicting mobility seemed to have a slightly stronger clinical effect size, with some of the associations reaching clinically significant effects, as evidenced by the 12 seconds cutoff at 8 years. The cognitive domain that seemed to have the greatest predicted effect for time get up and go decline was sustained attention, followed by processing speed. Interestingly, computer-based cognitive tests. Baseline time get up and go was weakly associated with change in cognitive parameters, and all effects were very small clinical significance. And the effect of time get up and go on change in processing speed seems to be strongest, though the overall model had porous fees. And the effect of time get up and go on change in sustained attention was smaller, but statistically, TUG explained more variance in sustained attention values at wave 3. So the bottom line is that in both directions, we saw sustained attention and choice reaction implicated or suggested that they had some significant effects more than the other 3 cognitive domains. We saw this choice reaction time effect also separately in a separate paper that was led by a medical student here in Trinity College, Dublin, called Renuka Chintapalli. And based on the TILDA ISSD8 public dataset, which is a public version of the TILDA dataset that's stored in the Irish Social Science Data Archive, which is free of use for research, we demonstrated that the time get up and go also had divergent trajectories depending on how you grouped wave 1 motor response time of the choice reaction time test in that baseline sample. So in this case, utilizing at repeated measures analysis of variance design, we did demonstrate how at 4 years there seemed to be a divergence of mobility, whereby those who had a motor response time average of greater than 250 milliseconds in TILDA seemed to have, after adjusting for multiple confounders, an accelerated pattern of mobility decline, which was not strongly clinically relevant, but certainly statistically relevant, and perhaps over a longer period of time would have become more clinically significant. One of the insights that we've learned from this is that in population-based studies, mobility decline and cognitive decline obviously move very slowly. So you have to be patient, and it wouldn't be a good idea to stop your longitudinal study at 2 to 4 years, where actually you're more likely to see effects at 8, 10, 12, and 20 years. So what else are we doing in frailmatics? Dr. Rosella Rizzo, our Italian mathematician who is working on the frailmatics grant, became very interested in the sustained attention reaction time test as well. So first of all, we needed a new method to visualize these very complex data sets that emerge from the computer. And we hypothesized that for certain computer-based tasks, such as the START, perhaps we have a threshold effect rather than a single mistake being actually clinically meaningful. a lot of participants and patients in clinics often are quite apprehensive and anxious about making small mistakes in cognitive tests, where sometimes clinically we think that when we see a pattern or a threshold that might be more clinically relevant than just the odd single mistake, and that could be actually quite reassuring for participants and patients in real clinics. So we really wanted to see if we would see a specific subset of participants with poor SART performances with more specificity, and then explore correlations with mobility and cognitive decline. So this work has been published recently in NDPI Geriatrics, and Rosella, through mathematical formulas and with a data-driven approach, established the thresholds of poor performance for the SART test, which in this case mathematically was defined as the number of times that a participant did at least 4 mistakes in a single SART trial. The SART is actually 23 trials. So in every trial, the participant sees the series of numbers 1 to 9. And remember, every time you see number 3, you have to not press the button. So making 1 or 2 mistakes could be relevant, but may not be relevant. So in this case, we hypothetically said that at least 4 mistakes in a single trial amounted to what we call a poor performance. And of course, the number of times that participants make a poor performance then is illustrated here in black spots, where in the x-axis you have the chronological age. On the y-axis, you have the response time, so the milliseconds response time in every single trial. And essentially, the size of the black spots is proportional to the number of times that the participants made at least 4 errors in a SART trial. So it is a nice sea of data. Of course, it's very difficult to visualize that data, but Rosella did it very nicely with this complex bubble chart. And you can then simplify it on the bottom chart by actually, removing the C of wellness and then coming up with, the poor performances. And you can see quite obviously that poor performances in the SART test are quite dependent on chronological age, where, older participants tend to make more threshold mistakes. And of course, this visualization was quite interesting because you could superimpose TOC, MMSE, and the absolute number of mistakes on those lines above the graphs. So it gives you a way to really generate visual hypotheses, which is something that we believe in the Informatics program. So there are 4,864 participants in this SART visualization at wave 1, and there were a total of 1,222 bad performance at wave 1 for 565 individual participants. And you can see that from 8.2% of bad performances in 50 to 64-year-olds, you get to 33.7% in 75 pluses. So the number of times that you make that threshold mistake in the SART, we postulated might be an independent risk factor for mobility decline, as assessed by the TOG at 4 years, and also new falls. So people who were not reporting falls at wave 1, recent falls, but then at wave 4 did report that they had falls in the past year. And when we adjusted by the mean response time, standard deviation of response time, age, sex, education level, anxiety, depression, medications, comorbidities, toxic habits, physical activity, usual gait speed at baseline. Actually, the number of bad performances in the SART was quite strongly and independently predictive of both mobility decline and new falls, where the absolute number of mistakes, as in mistakes in good performances, when they hadn't met this threshold, actually that didn't really predict mobility decline and falls. So that really seemed to indicate that it's a threshold effect that seems to be associated with the poor outcomes, but not necessarily little mistakes that happen here and there that do not hit the threshold. This is what we call mistakes in good performances. It is an interesting paper. It's out there, as I said, in MDPI Geriatrics. And if you would like to know more about the methodology and about how we define the various tasks, I would really encourage you to have a look at it. But we thought in cognitive performance, as we say in English, that one swallow does not make a spring. So sometimes it is possible to reassure an anxious patient. If you only had make a little mistake, it's maybe perhaps not clinically relevant. It's when you see a pattern or a threshold effect that things might be a little bit more concerning. So just to extend this work, Rosella was looking at longitudinal SART performance because, of course, wave 1 and wave 3, they did both longitudinal, so the same SART test, same computer-based test for the same participants. So so within we were able for 3,472 participants to actually superimpose the SART data at wave 1 with the SART data at wave 3 4 years later. And in this particular case, we performed fuzzy clusters to find out patterns of similarity or dissimilarity between the same participants. And you see that most participants, 3,258, perform very well at both wave 1 and wave 3 4 years later. That's the blue group. A smaller group, 177, the green group, they had an intermediate pattern of reasonably good performance at wave 1 and perhaps a slightly different performance at wave 3. But there was one group, a very small group, only 37 participants, that they did really, really well in wave 1, but very bad at wave 3, and so that group was small but interesting. And when we characterized those fuzzy clusters, we saw that that very small group of 37 tilde participants not only had significant mobility decline, but also usual speak decline, time get up and go decline, but in that particular small group of participants, there were also significant cognitive decline. Where in the population-based study that we see, it's quite difficult to see cognitive decline based on the healthiness of the population-based sample and perhaps some learning effects over time. Actually, we think that could be clinically relevant, but it only happens in an overwhelming minority of population-based participants. And this is why we think that performing these studies on more and frailer clinical cohorts could be necessary as well, because population-based studies sometimes don't really show you too much pathology, and it's hard, and you have to do very fine clustering and precision phenotyping to come up with a very small amount of population-based participants that have pathology. So, in conclusion, we know, and we're here for this, that cognitive processes do play an important role in the control of motor functions. And it is very important to incorporate the examination of cognitive functions as early as possible in older people, even when they look okay and their mobility is independent. And it is important that clinicians take subtle changes in cognition seriously, especially when subtle mobility impairments emerge over time, as this may provide them the opportunity to offer disability-slowing interventions when they could be most effective. We need to gain a greater understanding of the relationships between different types of cognitive tests and different types of mobility impairments. And so we really would like to aid clinicians in their choice of cognitive assessments to support these personalized management plans for individuals that perhaps may be at risk of this physio-cognitive decline syndrome and related syndromes. And I would argue that in particular, these computer-based cognitive tests of sustained attention and choice reaction, for some reason, we're still quite puzzled about this, are actually showing the best correlations in our population-based study. And we perhaps need a little bit of help and collaboration trying to interpret the meaning of this. And Tilda in Wave 3 did some MRI studies on a subset of about 500-600 participants. And we may need to look into that in terms of trying to understand perhaps certain patterns. But it's difficult and we need a little bit of help. It would be interesting to see the discussion. So results really may stimulate further research into common cause mechanisms of functional and cognitive decline. So to finalize, again, thanks very much for the opportunity to present at this very exciting symposium. Just acknowledge our funders, Science Foundation Ireland, and Tilda funders, which are the Department of Health and the Health Research Board here in Ireland, the Atlantic Philanthropies, and the Irish Life. So thanks very much for your attention, and I look forward to the discussion.
感谢3位讲者为我们带来精彩的演讲。现在为综合讨论时间，有请讲者来到台前，欢迎各位学员踊跃提问发言。Thanks for all the professors giving us the wonderful speeches. Now it's general discussion. Sincerely invited all speakers come to the stage.
Okay, now we come to the discussion section. There are several questions from the audience. The first one is for Dr. Zhong. What do you think is the reason that small vessel disease only related to PCDS, but not MIND or CIND?
First of all, we have to be clear that when we say MIND and CIND, they are not disability and they are not demented, and they are from a community. Their mobility function is poorer and their cognitive is more impaired than the others. So I believe that you raised this question because you think there is a lot of studies which show that small vessel disease is associated with gait disturbance and dementia. So we are looking at different stages of disease. So maybe at the very, very early stage of functional decline in the elderly, small vessel disease is only related to PCDS, which we have defined them as the study target or the treatment target. And this result prove that our definition is very optimal and just like our imagination. They are very practical to choose them because they are more yield and they are more prone to future mobility. Thank you.
Thank you. Another question is also for Dr. Zhong. Thanks for the informative talk. I would like to ask if there is regional difference of the lower GMV of the PCDS group in comparison with other groups.
Actually, we have already published this data. Yes, but today my topic is not about the gray matter volumes. We are talking about gray matter-based brain age. So it's okay. I can talk our previous study. Yes, the regional gray matter volumes associated with PCDS is located at the hippocampus and the cerebellum.
Okay. If the audience have further question, maybe you can follow up later. Another question is for Ms. Lu. In the French cohort, 2/3 of the PCDS subjects reverse to non-PCDS status. What do you think is the reason for this result? Any factors known to you that can be used to identify people with better reversible capacity?
Thank you for this question. This is a very great question. Yes, as I show in the presentation, even in the MAP control group, which means that those people who didn't receive any multi-domain intervention or omega-3 supplementation, these older adults can automatically reverse back to the non-PCDS stages. Although like in the presentation, I grouped everyone together, so maybe we can look for a detail to see that is exactly the PCDS participant refers back to robots, or PCDS have some recover from mobility impairment or recover from cognitive impairment. I think they can have different reasons that between these two recovery trajectories. And I think the reason is something now we are trying to working on. So now we use the observational study to try to first prove that, yes, if we use the correct tool, we can identify the group of people, even they have cognitive impairment and mobility impairment, but they can reverse back. So once we can identify these people, I think we still need to work on to see the details. For example, what is exactly the biological profile different between them? Maybe they have some genetic difference, or maybe they have better physical resilience to allow them to reverse back automatically. So I have to say that I don't have the good answer for this question yet, but I think this question is now in the geriatric field, we would like to try to working on.
Okay, thank you. Another question is also to Ms. Lu. Do you have data or prevalence to compare PCDS that is defined by ICOP tool or original definition of the French cohort?
Yes, that's also another excellent question. I think the question is that based on the same map participant, is there any difference between the preference when we use the ICO indicators or when we use the original PCDS definition? And here I only have the preference result when I use the slowness and weakness as to define physical impairment instead of chair rise. And I can say that the preference actually is exactly the same when we use the ICO indicators. As I present in the presentation, that is around 9% of the participant with physical impairment when they use ICO indicator. But if I use the original PCDS definition to define MIND, I got some 11%. So actually it doesn't change a lot. But for the cognitive domain, since we have a lot of measurement we can choose inside the map study, so far I don't have an exactly preference for that. But I believe that because my participant is quite very fit, so probably based on these two definitions, the original PCDS definition and the ICO indicator, we will get the similar preference. And compared to another clinical randomized control trial I mentioned in Taiwan, the FIS, probably the MAP participants have pretty much lower prevalence compared to that Taiwanese study, even use the same PCDS definition.
Thank you. The next question is for Dr. Lohman. Ms. Lu mentioned a high resolvability rate for the PCDS subject. That's about 68% in the longitudinal observation. Do you notice a similar reversible presentation in your study? Dr. Lohman?
Thank you very much. In terms of our study, what we did is a data-driven approach. Of course, we did select a range of cognitive measures, and we chose the time get up and go as the measure of interest. We did not depart from the definitions that have been proposed in terms of PCDS or others, but we did essentially generate a data-driven approach that allowed us to then compare in this study which of the cognitive domains was more related to mobility and vice versa. So I don't have the straight answer to that question, I'm afraid, but we could look into that in the data set.
Thank you. So now let's open to our audience. Do you have any questions or comments for the three speakers?
I have
Yes,
a question
yes.
for Professor Roman. And thank you for your lecture. I'm very impressed by your interesting results and a lot of computer-based cognitive evaluations. There's a point that I want to raise about the time up and go test. When you wanted to evaluate the relationship between mobility or physical function decline and cognitive impairment, if we use time up and go, this test compared with the 6-minute walking speed, maybe it's not purely based by our physical function, because it's more complicated. Time up and go, and then you have to turn and walk back. Maybe you need more processing speed or attention ability. And this postulation is also confirmed by your results. Time up and go is more likely to be associated with the speed processing and the attention ability. So do you have any opinion about this thinking? Thank you.
This is an excellent question, and thank you very much. And I agree. I agree because if we have a look at that paper that was published in Geriatrics by Rosella Rizzo, and looking at the threshold effect of the SART predicting mobility decline and falls, we also did a sub-analysis as to whether the change, so whether the threshold performance mistakes in the SART was also predicted of usual gait speed decline. And you will see in that paper that it didn't hold true. So SART was predicted of TOC decline, but not usual gait speed decline. And as you say, we phrased it in a way that we think that time get up and go is more cognitively involved than usual gait speed or perhaps 6 meter, so other non-cognitively loaded tasks. So yeah, I do agree. I think the time get up and go is more complex and has more cognitive components than usual gait speed. I would argue, and of course, we need to have a neuroscience collaboration about this. So what are the areas that the time get up and go test is actually employing? And are those the same areas that then might be involved in cognitive decline and specific domains of cognitive decline, especially the, as you say, attention and executive function. So in my theory, if you don't mirror the kind of potential biological substrate of mobility and cognition, you're not going to connect them in the analysis. And clinically as well, a lot of geriatricians do like time get up and go a little bit more than usual gait speed. I'm not sure what your opinion is on that, but it is a bit richer. I do agree on your point, and I think it's a point that we should perhaps investigate more in terms of why is that connection there and not with less cognitively involved mobility tasks. I fully agree.
Thank you. Thank you, Dr. Roman's answer. Dr. Arai, do you have a questions?
Yes, I have a question
I see
to
you,
Lou.
yeah. Please.
Yes, I have a question to Lou. You already mentioned my answer to Michelle, but let me confirm. So in your study, more than 60% of the participants of PCDS were reverted. So more intervention group was included in reverted group than in the control group.
Hello, Professor. I would like to check the answer again. Yes, for the first one, yes, more than 60% of MAP participants in control group is reversed. And your answer is, why is that? How is the percentage of the whole MAP participant? Is that your question?
Yeah, I think the intervention group should be reverted. A more intervention group of participant with PCDS should be reverted than the participant in the control group. That's what I think. Is that right?
I also ran the similar analysis among the whole MAP participants. So I also got around 68%, as I remember, like similar preference among the whole participant group. But I didn't look for the detail that into the each intervention group, which means that probably it can have a detailed look to see that whether under multi-domain plus omega-3, maybe they have a little bit lower reverse preference. But yeah, it's a very interesting idea. Yeah, I can do for that. But generally speaking, if you just look at the whole participant, the preference is similar.
In terms of the mechanism, do you have the data of the ApoE4 or brain imaging in this cohort?
Yes, in MAP participant, we have a subgroup, a subsample of the MAP population who have ApoE4 data, and MRI and PET scan. Yes, we have this data. Yeah, but yeah, I didn't check the association, but I think it's also another very interesting idea. Like, yeah, it can maybe help us to answer the previous question that maybe these two markers can give our answer whether those refers back to non-PCDS, those PCDS patient refers back. Is because they are non-ApoE4 carrier, or is because they have better neuroimaging indicator? Yeah, I think it's very interesting topic that I should look for. Thank you for your comments.
Thank you very much.
When we are looking at this high proportion of the reversible, do we have to concern about the unstability? Because about 70% in the control group, they can be reversed to the status can be reversible, interchangeable. Do you guys think that the original definition of the measurement has to be refined, or the mechanism has to be further investigation? Any speakers or audience can answer my questions?
If I may, to that question, I would perhaps echo the previous point that it's really interesting to see definitions and hypothesis-driven definitions of various cognitive and mobility decline syndromes. And at the same time, it's very interesting also to provide data-driven approaches to see how they mirror the hypothesis-driven concepts. As it happens with other constructs in geriatrics, for example, frailty or delirium, etc. So there is a lot of complexity in those concepts, and many definitions do have certain degree of overlap. But I think it's very interesting to operationalize as many concepts as possible in large data sets to see how they compare, and also to make the point that these are very, in particular, physio-cognitive decline syndrome and related syndromes are very slowly occurring. So it's really necessary to have a very long time of follow-up to understand these very slow-moving relationships, especially when you talk about population-based studies. But data-driven approaches, as we can do in informatics, I suppose, they are a complement to the pre-established definitions, and sometimes perhaps could add some clarity and consensus, help consensus as well.
Yeah, Dr. Chen.
Thank you. That I think in MAT, the observation period is only for 3 years. And it's not really a control group because once you are enrolled in the study, there must be some effect. So, but on the one hand, it's a good thing that even with some generic education or participating in certain trial in the control group, still change your lifestyle, and that also highlight the that selecting PCDS as a target is relatively easier to reverse compared to those who had more severe symptoms and then it may be irreversible at all. On the other hand, that we have the ELIS cohort for 8 years to see how the PCDS become in 8-year observation period. Overall, it's a progressive, overall. So some become incident dementia, some incident disability. Of course, some of them remain or reverse, but generally speaking, in 8-year observation, it is progressive, still progressive. So I would say maybe MAPT is a clinical trial that may be different. Even the control group is not a real control. It is still some health education and lifestyle modification will be educated. But they also enhance the possibility that we don't need to spend so much effort to do the health promotion for those people. But I do have another question for Roman. That in your data, you see that people with cognitive impairment can predict mobility decline, and vice versa for the mobility impairment. Do you think the two phenomena are identical, or they're having different pathophysiology? Because from the previous intervention trial, but that is not specifically designed for PCDS. That is a subgroup secondary analysis based on the previous randomized control trial. That the intervention effect on the MIND, the mobility impairment, versus the CIND, cognitive impairment, are not the same. So the intervention effect are not the same, although they predict each other. But do you think that's the same mechanism, or eventually or just because you use time mapping goal that is more cognitive driven mobility test?
That is a very deep question, and I hope I can give you some insights based on my experience so far. I think we may be seeing the same or similar pathophysiological mechanisms in those two directions, but I think what was really interesting to me is to see that the participants, were so well, and you cannot see any deficits. You sit down in front of a computer, you perform the task, they do a time get up and go of 8 to 9 seconds, and they go home, and everything seems hunky-dory. But at 8 years, those who were 2 standard deviations above that, they have reached a significant mobility decline. So I suppose, it's a very early stage, and I suppose when someone has already mobility decline, then I suppose you're looking at a different timeline, I think. I think, even though, for example, cognitive deficits may then lead to cognitive decline, when you see cognitive deficits first, you might be looking at a very, very early stage of whatever pathology is going on. Whereas when you actually have hit the mobility decline stage, you will develop further cognitive decline, but I think you are a little bit more affected by pathology, whether it's the same pathology or not. I think you're looking at different types of clients, perhaps with similar pathophysiology at different stages of the life course. So that's my best bet. But I cannot be sure because, of course, the TILDE study does not have a lot of mobility decline and severe morbidity and disability. So what types of cognitive declines that leads to, you could make your own clinical hypothesis. but I don't think we have that until then.
Thank you.
Thank you. Thank you, Dr. Roman. And also thank you all of our three speakers. Excellent talk. Because the time is about, the time is almost up. So let's finish this section. Thank you for all of our speakers and audience. Thank you.
感谢各位踊跃的提问及发言。现在为大合照时间，有请所有讲者来到台前合影留念。Thank you all for your participation and comments. Now, sincerely invited all speakers come to the stage to have a group photo. Okay. 1, 2, 3, cheese. One more. 1, 2, 3, cheese. Thank you. 感谢各位贵宾，请陈院长留步，其他贵宾请就座。最后，让我们欢迎台北市立关渡医院陈亮恭院长上台为我们进行闭幕致辞。In the end of the symposium, we're delighted to welcome Professor Liang Gong Chen, the Superintendent of Taipei Municipal Gandao Hospital, to give the closing remarks.
Thank you very much. I don't know how many people are still online, but still, thank you all for the attendance for the whole day symposium. That is very, very fruitful and inspiring event that is not necessary to be, Physio-Cognitive decline syndrome, but this phenomenon, the mobility and the cognitive co-occurrence phenomenon, is very important. In terms of the healthy aging or to prevent further adverse event. So different research groups are trying to hypothesize or to conceptualize those phenomena into the operational definition and prove whether this is a suitable definition. And this is what we're doing in the past few years. And we found this is a good operational definition, but still there are a lot of challenges. We need more data to support a more generic and it can be widely applied to different cohorts in the future. So thank you all, and I know that in theory we're initially hoping this symposium to be held in Japan. I have talked to Professor Alai for many years, and I'm hoping that next year we're going to see each other physically in Japan and to have more face-to-face discussion. I'm hoping to have more collaboration from other research groups to get this concept being implemented in the real practice. The main purpose is not about the terminology is not about the paper. The most important of all is about to promote healthy longevity for this super-aged society. So thank you all for the whole day attendance and look forward to meeting you all in the near future. Thank you.
感谢陈亮恭院长的致辞。Thank you, Professor Liang Gong Chen. 各位来宾，今日的研讨会到此结束。感谢各位来宾的参与。为避免影响学员权益，再次提醒，请所有学员于离开前记得完成线上签退表单以及满意度调查表，缺一项皆无法申请学分。感谢大家的配合。It's the end of the symposium. Thanks for all your participation and cooperation. See you next time. Bye bye.